Okay, welcome everyone. My name is Dr. Karagesian, or Dr. K, or Dr. Greg, and I do voiceovers for a variety of classes, and we're going to do a module on respiratory assessment and care modalities. Okay, so it's interesting stuff. There's going to be a number of terms that I'm going to discuss. Then we're going to go into procedures. We're going to discuss oxygen therapies, intubation, ventilation of patients, in particular mechanical ventilation. Okay, so I'll try and clarify these terms for you so that they make sense as you go forward. Okay, so let's just start with some terms. Okay, we're going to cover these in this module, but it's just nice to hear terms first before we actually get right at these different titles. So gas exchange, well, what's gas exchange, right? When we're talking about gas exchange, we're referring to oxygen getting from the alveoli into the pulmonary capillaries, so the pulmonary blood supply, so that it can then go to the left side of the heart and then be pumped out once the blood's been reoxygenated and CO2 has been taken out of the blood. Okay, so O2 goes from the alveoli into the capillaries, and CO2 goes from the capillaries into the alveoli to be exhaled. Okay, so that process I just described to you takes place at the alveolar capillary junction. It doesn't take place in the bronchial tubes in the alveoli capillary interface. Okay, and that's what diffusion is. That's diffusion of gases across that membrane. Okay, what's perfusion? Perfusion always means blood supply or blood flow. So if we talk about pulmonary perfusion, it just means the blood that is being perfused to the lungs, and in particular all those millions of alveoli, to be reoxygenated and for carbon dioxide to diffuse into the alveoli to be exhaled. Okay, so I can say the term renal perfusion. That just means blood supply to the kidneys. Pulmonary perfusion, where does it come from? The right ventricle pumps into the pulmonary artery. The pulmonary artery splits, one to the left side of the left lung, one to the right lung, and then gradually it will become capillaries at the alveolar capillary membrane. Ventilation is purely just the process of getting the air from your mouth to the alveoli. Okay, so that's going to be more affected by conditions that are affecting the bronchial tubes or the trachea. Okay, so think of perfusion as the blood supply, diffusion taking place in the alveoli. Ventilation is just you breathing in and out to get the air or oxygen to the alveoli. Okay. So if I said someone has a ventilation problem, well, they have a problem getting the air to the alveoli. So for example, someone with asthma, someone with, say, cystic fibrosis, someone who's overdosed on opioids. Well, they don't have a problem with their alveoli. They have a problem with their breathing, which is their ventilation. If someone has a pulmonary embolus that's traveled to their lungs, they have a problem with perfusion because an artery is blocked, stopping perfusion of blood to the lungs. And diffusion, well, anything that affects that interface between the alveoli and the capillaries will affect diffusion. So how about pulmonary edema from congestive heart failure? Pneumonia that's causing fluid to fill in the alveolar sacs. Okay, so those would be diffusion problems. Okay, so we're going to talk about chest x-rays. Why do we do a chest x-ray? Well, a chest x-ray gives us a view of the heart. So it'll tell us, is the heart enlarged? For example, in congestive heart failure. Okay, we often look for cardiomegaly on chest X-ray um, in someone who has potentially congestive heart failure. We look at the lungs. So what can we see on the lungs? Well, we can see emphysema. The lungs are really enlarged. The diaphragms are flattened. The lungs are typically what we call hyperinflated because patients with emphysema or COPD, they have damage to the alveoli and the lungs don't recoil well. So they're breathing at high lung volumes. Okay. So we can see the heart on chest X-ray. We can see the lungs on chest X-ray, looking for a pneumonia, looking for COPD. We can see a pneumothorax, a collapsed lung on chest X-ray. We can see a pleural effusion, which is a collection of fluid in the pleural space. We also get views of the ribs, so sometimes we can see rib fractures. Okay, so an assortment of conditions we can use a chest X-ray for. Sputum samples are typically used for sending to the lab to examine for potential infections. So whether we're talking about bacterial infections or mycobacterium, that's tuberculosis, we can send those to the lab to see if we can culture any type of potential infection. A laryngoscopy is a short tube or a short camera that gets inserted into the mouth to look at the larynx. So we can see the posterior pharynx, so the back of your throat as the camera goes in, and then it points downwards and we can see the vocal cords, the epiglottis, and typically that's used for someone who has symptoms such as hoarseness, or say they had some bleeding from the back of their throat, and we look back with a camera to see if there's any pathology such as cancer. Okay. Pulmonary function tests we'll talk about. They're to assess lung volumes and the flow in the bronchial tubes, so the flow of air. We'll come back to that. Arterial blood gases, well, we'll talk about those. We get a direct arterial sample of blood by inserting a needle into the radial artery at the wrist, and we get blood gases, and they're used to interpret different values on the blood gas. Typically when someone is short of breath and we want to see all of their arterial blood gas values. Thoracentesis is a procedure where we typically insert a needle into someone's back where the lungs are. And what do we want to do? We want to drain a pleural effusion. Okay, so a thoracentesis is used for draining fluid in the pleural space. It's not for going into the lung. And we want to see if the fluid is blood. We want to see what's in the fluid when we suck it out. So we'll send it for culture. We'll send it for an assortment of tests to see where this pleural fluid is coming from. And we also do it not only for diagnosis that I just mentioned, such as cultures and testing of the fluid, but also for symptomatic treatment. So someone who comes in with a really large pleural effusion, well, they're short of breath, they're uncomfortable, they can't lie down because they're so short of breath. So we can use a thoracentesis to drain the fluid out so that they're breathing better. Okay. Bronchoscopy is basically a camera that goes into your mouth, down your trachea, and we use it looking typically for lung cancers. The symptom that someone will usually come in that warrants a bronchoscopy will be coughing up blood, or we see a lesion on chest X-ray and we think it might be a lung cancer and want want to get a sample of it, well, we can use bronchoscopy, get to the area, and then actually take a sample, a biopsy of the lesion, and then send it to pathology. Pulmonary angiogram, what is it? It's just a dye test. So we'll inject dye into a patient's vein and then wait for it to circulate through the pulmonary circulation, looking for any areas that are blocked or that are abnormal, that have abnormal blood flow through them. Okay, we'll talk about that a bit more later. Thoracentesis, that we've already spoken about that. Sorry. Lung biopsy. Lung biopsies are usually done with a needle through the chest in the area of concern to take a biopsy of the lesion and send it to pathology. Okay, so if we suspect lung cancer, a lung biopsy is often done if the lesion is close enough to access it with a needle. Okay, a VQ scan is just another term for ventilation perfusion scan. It was an older test that we don't typically use very much anymore, and it was to look for pulmonary emboli. Okay, so what does ventilation perfusion scan mean? Well, it's a scan that looks at someone's lungs to see where the air is going while they're breathing in both lungs, and at the same time, it's able to look at the perfusion of the blood vessels through the lungs, and they should match up perfectly. So where the air is going throughout your lungs should match up with where the blood's going through your lungs. And if we get what's called a VQ mismatch, then there's a problem. There's either a problem with ventilation, the air is not getting to a certain lobe of the lung, or there could be a problem with perfusion, meaning something is blocking the flow of blood to that area of the lung, and that is frequently a pulmonary embolus. So a VQ scan is typically done to rule out a pulmonary embolus. We don't use them very much anymore because we use a CAT scan. Okay. So a spiral CT, or we'll get a bit more specific, a spiral CTA. So a CTA is just a CAT scan with dye, a CT angiogram, and that is what we use to try and diagnose pulmonary emboli. So patient gets injected with dye, and then they go through a CAT scanner looking for any blocked arteries in the pulmonary system to diagnose pulmonary embolus. That's by far the most common test we use now to rule out pulmonary emboli. Okay. A D-dimer, it's just a basic blood test that is to try and pick up any active clotting in the bloodstream. So we use this test to try and diagnose or rule out a deep vein thrombosis or a pulmonary embolus. So if someone comes in with a swollen leg, one leg by the way, not both, swollen, tender, a bit red, we can send off a D-dimer test to see if there's clotting going on in the system because we suspect that they have a blocked vein. Okay. So it's not a very sensitive test. So if the D-dimer came back elevated, meaning abnormal, we would have to go on and say they had a swollen leg, we would have to go on and do an ultrasound of the leg to see if there's an actual clot in the vein. If they came in with symptoms of a pulmonary embolus, such as shortness of breath, coughing up blood, pleuritic chest pain, and we have a positive D-dimer, well, we still have to go on and do a confirmatory test, which would be the spiral CAT scan, okay, or a spiral CTA. Okay, so we'll go through these again. Okay, so let's talk a bit about pathophysiology in the upcoming slides. This will be a bit of a review. but it's important because that's what's going to help you understand the other material, right? So the basics is what helps you understand the details later on. Okay, so oxygen transportation. So how I think of that is, okay, I need to get air from my mouth to my alveoli. Okay, air is 21% oxygen. It's mostly nitrogen, actually. So how do I do that? Well, that's through ventilation. Okay, by having my rib cage expand and my diaphragm go down, so contraction of my intercostal muscles, and my diaphragm allows for negative pressure to occur in my chest. So I'm taking a breath in, so there's going to be negative pressure, and that's going to suck air in from my mouth to the alveoli. Okay, that's ventilation. What's compliance? Compliance is really just talking about the ventilation. So are the lungs normal? Do they expand normally? Or are they stiff and non-compliant? Okay, so if someone has, for example, pulmonary fibrosis, they have really stiff lungs. It's hard to take a big breath. Okay, so their ventilation will be impaired. If someone is morbidly obese, well, they have a lot of tissue on their chest wall, and it's going to be hard to take a big breath. Okay, and that's why we're careful not lying people flat when they're really short of breath. Because now, when they're lying flat, their diaphragm has gone up into their chest cavity a bit, and they're trying to ventilate, but we've laid them flat, so gravity isn't helping bring the diaphragm down any longer. So they get more short of breath. Okay. So compliance you can think of as lung compliance and chest wall compliance. Is there something with the lungs that's stopping them from expanding when the muscles of the chest wall and the diaphragm contract? Or you can think of chest wall compliance. Is there something wrong with the chest wall that is stopping normal expansion and ventilation? So obesity is a good example. I guess an analogy would be if I tied a belt around someone's chest and asked them to breathe normally. They wouldn't be able to ventilate because the belt is stopping expansion of the chest wall. Okay? Diffusion is what I mentioned before. That's the process of where, in the alveoli, where oxygen crosses the alveolar capillary membrane into the bloodstream and reoxygenates the bloodstream, and at the same time CO2 goes down a gradient from the blood vessels, the pulmonary capillaries, into the alveoli to be exhaled. Pulmonary perfusion, blood flow to the lungs, right? That's all perfusion is. How is the blood flow getting through to all the different alveoli? And that's pulmonary perfusion. Okay, so oxygen transportation. So I spoke about getting the air from your mouth to your alveoli during ventilation. And now what has to happen? The oxygen has to cross the alveolar capillary membrane into the bloodstream, so into the capillaries. And so now you get a pressure of oxygen in your capillaries. So we call that partial pressure of oxygen. So your PaO2. Okay, that's all it means. It's telling us how much oxygen, when we do a test, is in the bloodstream. And then from there, the oxygen that's dissolved in the bloodstream has to then attach to the hemoglobin. And hemoglobin is what carries the vast majority of your oxygen. Okay, so how did it get onto the hemoglobin? The partial pressure of oxygen in the bloodstream is what forced it onto the hemoglobin. Let's go to the tissues. So all the tissues in your body, every cell in your body needs oxygen. So just think of an organ, whether it's your intestines, your liver, your spleen, anywhere else, your brain or your heart. So now the oxygen needs to get delivered to the tissues and the cells. So what happens? Well, the partial pressure of oxygen in your blood diffuses across the capillaries in your tissues and travels to the cells. Well, that's going to reduce the partial pressure of oxygen in your bloodstream. Okay, well, if that happens, oxygen is going to come off of hemoglobin now and continually come off of hemoglobin into the bloodstream that then can diffuse across the capillaries to the cells. Okay, and it's all about the fact that your partial pressure of oxygen went down because it's diffusing across the capillary membrane, getting into the interstitial fluid and then to the cells. And what was holding oxygen on the hemoglobin? Your partial pressure of oxygen. So that when that goes down, oxygen comes off of the hemoglobin. Okay? And the whole process will continue that way. So the deoxygenated blood from your tissues will travel back in your venous system, back to the lungs, get reoxygenated. CO2 will get into the alveoli and exhaled. Where did the CO2 come from? It came from cellular metabolism, right? Krebs cycle in your mitochondria produced as a byproduct CO2 and water, and the CO2 went back into the interstitial space, back into the capillaries, back into the venous system, back to your lungs to then get exhaled. Okay, so it's a continual process of being reoxygenated in the lungs, getting rid of your CO2 in the lungs, delivering the oxygen to your tissues, picking up the CO2 in the tissues to get it back to the lungs. Okay, so I'm going to say something pretty similar here. So let's look at the image on the right. So you have your pulmonary artery coming in. So by the way, your pulmonary artery is an artery that has deoxygenated blood in it. It's come from your right ventricle. Most arteries in your body have oxygenated blood, not your pulmonary artery. It has deoxygenated blood. Okay, so the pulmonary artery delivers blood to the lungs, deoxygenated. Okay, but the alveoli, through ventilation, has oxygen in them to diffuse across the alveolar membrane into the capillaries and reoxygenate the blood. Okay, what's happening at the same time? The CO2 is diffusing across the capillary and the alveolar membrane into the alveoli to be exhaled. And now your pulmonary vein has oxygenated blood, and it has lower CO2 in the blood. Okay, and we can go, so that's what's happening in the lungs, right? Between the air and the blood. Okay, between the blood and the cells, we've already spoken. Oxygen leaves the capillaries, goes into the interstitial fluid, then goes into the cells for cellular metabolism. It needs the oxygen. CO2 is high in the cells because of all the metabolism. It goes into the interstitial fluid and then back into the capillaries. We're talking about the tissue level here, to be delivered back to the venous system, get delivered back to the lungs, to diffuse across the alveolar membrane and get exhaled. Okay. So this is all about gradients. I didn't mention anything about using energy for diffusion. So oxygen in your alveoli diffuse into your capillaries in your lungs through diffusion. No energy needed. Okay, it's just a gradient, and the same for CO2. When the blood comes from the pulmonary artery, it's higher in CO2. So just through pure a gradient, the CO2 gets released from the blood into the alveoli. Okay, no energy required for that process. Okay, so ventilation we've spoken about. That's the process of getting air from your mouth to your alveoli. That's it. How does it happen? Well, you have a respiratory center in your brainstem that sends a signal to through nerves, of course, to the intercostal muscles in the diaphragm to contract. What happens? Well, when the intercostal muscles contract, it makes the rib cage expand. Okay, when the diaphragm contracts, it goes downwards. What's the overall effect? Increased volume of the thoracic cavity. Okay, well, your lungs are actually attached with pleura to the inner part of your rib cage. So if the rib cage expands, the lungs have to go with it. So they expand. Okay, and that's the process of ventilation. Inspiration is active. It takes energy to contract the intercostal muscles and the diaphragm. So normally, inspiration is the only active part of ventilation. Okay, what happens during exhalation? The intercostal muscles relax, the diaphragm relaxes, and because the lungs have recoil and they've been stretched during taking a breath, during inhalation, they now want to go back to their original smaller size. So they recoil. Okay? So that's normal inhalation and exhalation. And exhalation usually requires absolutely no energy. Okay? So what's happening to the volumes of the chest and the pressures in the chest during inhalation? Well, during inhalation, remember the chest cavity is getting bigger because the intercostal muscles in the diaphragm contracted, making the thoracic cavity, where the lungs live, larger. And it pulled the lungs with it. And by making more volume, you created less pressure. And that's what allows air to be sucked from your mouth into your lungs. Okay? It's the negative pressure in the thoracic cavity during inhalation. What happens during exhalation? Well, exhalation, the lungs want to recoil back. There's no contractions of the intercostal muscles of the diaphragm. So now the intrathoracic pressure is positive, and it's going to push air out of the lungs, back up through the trachea, and out through the mouth. Okay, so there's positive intrathoracic pressure during exhalation, and the lung volume or the thoracic cavity volume is diminishing during exhalation. Okay. So if I was to ask you during inhalation, is the volume of your chest cavity bigger or smaller? It's bigger. Is the pressure in your chest cavity negative or positive? It's negative. During exhalation, is the chest cavity getting smaller or bigger? It's getting smaller. So capacity is decreasing. Is the pressure positive or negative during exhalation? It's positive. Okay? So really what's happening during ventilation has nothing to do with the alveoli. It just has to do with air getting from the mouth to the alveoli. That's ventilation. So it has everything to do with the airway from your mouth into your trachea, into the bronchial tubes, and then delivering the air to the alveoli. It says nothing about the diffusion of oxygen and CO2 at the alveolar capillary membrane. Okay, and air just follows pressure. So just to be a bit repetitive here, during inspiration, you have negative intrathoracic pressure because of contraction of your intercostal muscles and your diaphragm downwards, and air gets sucked into the lungs. Exhalation, all the muscles relax. The thoracic cavity is going to get smaller. Why? Because the lungs want to recoil. They were stretched during inhalation. They want to recoil back to their normal size, right? And then the pressure in the chest gets higher and air leaves and goes out the mouth. Okay? So you can imagine if there's airway resistance, say you choke on a piece of meat and it gets into your trachea. Well, is that going to affect diffusion? Nope. But it's definitely going to affect ventilation. And it's definitely going to increase airway resistance. Okay? What's another condition that's going to affect airway resistance? Asthma. Well, asthma is bronchoconstriction and bronchial inflammation with more mucus production. So the airways are going to be constricted, narrow, difficult to ventilate. And that's why patients are short of breath. In particular, during exhalation, they can't get the air out. And they have wheezing when they're trying to get the air out during asthma or COPD. Okay. Why is it more difficult during exhalation to get the air out in asthma? Well, so there's bronchoconstriction and inflammation in the airways during inhalation and exhalation. But what happens, what changes during exhalation is that there's positive pressure in the chest cavity, which is making the bronchial tubes even smaller. Okay, because there's pressure, there's positive pressure because the lungs are trying to recoil. And that contributes to even more narrowing, and that's why asthma or COPD, it's usually expiratory wheezing. If you have inspiratory wheezing during asthma, you're in bigger trouble, okay? Because that's telling us there's really severe narrowing of the airways if you have inspiratory and expiratory wheezing, okay? So anything that impacts the airway from your mouth to your alveoli will impact ventilation. So I mentioned asthma, COPD. Well, COPD is made of two conditions: emphysema, chronic bronchitis. Emphysema is destruction of the alveoli. Okay. The chronic bronchitis component is destruction and damage of the bronchial tubes with excessive mucus production. That's what causes the wheezing and the narrowing of the airways in COPD. Cystic fibrosis, thick, tenacious sputum and damaged bronchial tubes. They get recurrent pneumonias, and they also have wheezing because the bronchial tubes are narrowed and filled with mucus. Okay? So anything that affects the airway passage and the bronchial tubes will increase airway resistance, and if you increase airway resistance, you cause increased work of breathing. So increased respiratory effort. Okay? Okay, so let's talk about the term compliance. And compliance just is another term for how flexible is this particular tissue? And when it flexes, does it recoil back to normal? That's all compliance means. So when we're thinking of compliance, there's two parts of compliance that we want to know about. The chest wall. So how compliant is the chest wall? How does it expand? And how does it recoil? Because you need that for normal breathing. And the other aspect of compliance is the lungs. How compliant are the lungs? Do they want to cooperate and open up and expand to allow air into the alveoli? And do they recoil normally? Okay, so chest wall compliance, lung compliance. Let's look at it, increased compliance. Oh, so what's going to cause increased compliance? So increased stretchability. Well, usually increased compliance from normal isn't really a great thing. It usually means that the lungs have lost lost some of their recoil ability, typically from emphysema. Okay, so emphysema is destruction of the alveoli and the tissue of the lung itself. So I mentioned that the lungs can expand, but then they have recoil ability. The tissue of the lungs wants to recoil during exhalation and get smaller. Well, if you have emphysema and you have destruction of the tissue of the lungs, including the alveoli, okay, no problem. You're kind of floppy now. You can expand during inhalation, but you don't recoil. So that's why patients with emphysema in COPD, they have barrel chests because they're breathing at higher lung volumes all the time because the lungs don't recoil back to normal. So they have a barrel chest. They usually have hyperinflated lungs on chest x-ray because the lungs never recoil back to normal. Okay? So increased compliance is not a great thing. You just want normal compliance. You want normal chest wall compliance and normal lung compliance. Okay? So under normal conditions, what should happen? The chest should expand during inhalation because of the intercostal muscles and the diaphragm, nice and smoothly. The lungs follow it because they're attached to the inner chest wall, so air goes in nicely. What happens during exhalation? The chest wall relaxes, nothing happening there, no muscles contracting anymore, and the lung recoil causes exhalation. Okay. What about decreased compliance? Well, let's talk about decreased lung compliance. Well, if you have stiff lungs, they're not going to want to stretch open during inhalation. So you're going to have to use more energy to open up the lungs, say in a condition such as pulmonary fibrosis. So what about someone who's got pneumonia in their lungs? Well, that part of the lung is not going to want to expand very well. So that's going to cause decreased lung compliance, right? Because it doesn't want to open up because it's filled with fluids. Okay. What about someone with pulmonary edema and they're trying to take a nice breath in, but their lungs are filled with fluid from back up from the left ventricle? They have decreased lung compliance. The lungs are wet. Okay. What if you have a pleural effusion or blood in your pleural space? Do you think the lungs are going to want to expand normally around all this fluid? No. So you have you have decreased compliance. Okay. Let's just think about the chest wall. What if someone puts on 100 pounds of weight? Are you going to have reduced chest wall compliance? For sure. You have extra tissue surrounding the chest wall that now your poor muscles will have to use more energy to expand that chest wall. Okay, so that's chest compliance. So morbidly obese patients can have very reduced chest wall compliance and make it very hard for them to breathe with minimal disease. So say they get a small pneumonia. So the pneumonia is now reducing lung compliance, and on top of that, they had reduced chest wall compliance to expand their lungs to begin with. Okay. Okay, so I'm going to do some questions at the end of chapter 17. Okay, these polling question slides, I just do some questions and explain them. So you can skip this slide and come back to it later. You can skip it entirely if you want, whatever works for you. Okay, so number one at the back of chapter 17, a nurse is caring for a client who is scheduled for a thoracentesis. Okay, that's just putting a needle into someone's pleural effusion and sucking lots of fluid out. Okay, prior to the procedure, which of the following actions should the nurse take? So a thoracentesis is where someone leans on a table typically with their arms and elbows, and we go in through the back with a needle into the pleural space where the fluid is and remove fluid. So A, position the client in an upright position, leaning over the bedside table. That would be the answer. Explain the procedure. Okay, that's not a bad option either, though. But it's saying that that's up to the provider. Okay, that's all right, because A is definitely correct. Obtain an arterial blood gas before the procedure. No, we don't need to do that. Okay, we don't need to get an arterial blood gas every time we're going to take fluid out of someone's pleural space. Administer benzocaine spray. So benzocaine is a freezing agent just for the surface of the skin. This patient would definitely need more freezing than that. So we would inject freezing into the skin, into the tissue below the skin, through. So the needle has to go to get to the fluid. It has to go through an intercostal space. So we freeze all the muscle of the intercostals where we know the needle is going to go into, because that'll be really painful. And we actually freeze down all the way to the pleura, because the pleura is incredibly sensitive. It has lots of nerve endings. So we freeze the whole distance from the skin all the way to the pleura before we do the procedure. So it's not just a spray. A is the answer. A nurse at a provider's office is reviewing information with a client scheduled for pulmonary function test. Which of the following information does the nurse include? Do not use inhaler medications for 6 hours following the test. No. Right after the test, you can start your inhalers again. Do not use tobacco for 6 to 8 hours prior to the test. That's true, because smoking is an irritant. It can affect the results of the test. So we want a test where someone has not had any smokes prior to it. So B is true. C, you will be asked to bear down and hold your breath during the test. No, that's a Valsalva maneuver. You wouldn't be asked that during pulmonary function tests. Okay, you would be asked to take really large breaths and exhale completely and as fast as you can, but you wouldn't be asked to hold your breath and bear down. The arterial blood flow to your hand will be evaluated as part of the test. No, that's for an ABG, arterial blood gas. Okay, so the answer is B. Okay. A nurse is assessing a client following a bronchoscopy. Which of the following findings should the nurse report to the provider? Blood-tinged sputum. No, that's not really uncommon, especially if a biopsy's been taken. You can cough up a bit of blood after, so that wouldn't be uncommon. Non-productive dry cough. No, that would be normal because the trachea has been a bit irritated from the scope going down with a camera on it. Sore throat. No, that would be normal too. Bronchospasms. That shouldn't be normal. Bronchospasms meaning you're getting constriction of the bronchial tubes, and that can become an airway issue and concern. So the answer would be D there. 4, a nurse is caring for a client who is scheduled for a thoracentesis. Which of the following supplies should the nurse ensure are in the client's room? Okay. Oxygen, definitely. One of the risk factors of a thoracentesis is we touch the lung with the needle and cause a pneumothorax, so the person might need oxygen. Incentive spirometer, no, we wouldn't need that. That's just a machine where typically post-operative patients it's a machine that encourages them to take big breaths with a little ball that goes up and down. Okay, so that's really a post-operative device to help and encourage patients to take deep breaths. Pulse oximeter, definitely. we'll have a pulse oximeter on someone's finger to monitor their oxygen saturations. Sterile dressing. Definitely a sterile dressing we would want to put on the site after the procedure. So once we've drained fluid out of the pleural space, we'll put a sterile dressing on afterwards, right? Because we've actually punctured right through to the lungs. We want to make sure that the site is clean. Suture removal kit. No, there's no sutures involved at all. Okay. Typically with a thoracentesis, there is no sutures because there was just a needle poke that went in. So it's not like a chest tube. It's just we went through the chest wall with a needle to take fluid out. Okay. So the answer would be A, C, and D. Last question. A nurse is caring for a client following a thoracentesis. Which of the following manifestations should the nurse recognize as risks for complications? Dyspnea. Yep, because you can deflate a lung. So you can create a pneumothorax with a thoracentesis because it's a needle going into the pleural fluid. But if we touch the lung, it can collapse. So dyspnea for sure. And localized bloody drainage on the dressing. Well, that would be expected. It wouldn't be a complication. Just a bit of bloody drainage on the dressing would be normal. Fever definitely would be a concern because it's an invasive procedure. So if someone develops a fever later, we're concerned about infection. Okay. Hypotension, that would be concerning after a thoracentesis because maybe we hit an artery going in. Maybe we hit some kind of blood vessel that's continually bleeding. Okay, so hypotension would be a concern once we've put a needle through someone's chest wall to drain fluid. Okay. Report of pain at the puncture site. No, that would be expected, especially once the freezing comes out, that there would be some discomfort. Okay, we'll go on here. Okay, so diffusion and perfusion we've spoken about. Diffusion is purely about oxygen and CO2 at the alveolar capillary membrane. Okay, so it's just the exchange of oxygen going from the alveoli into the capillaries to increase oxygen levels in the blood and also on hemoglobin, of course, and for CO2 to diffuse the other way from the capillaries into the alveoli. Okay, no energy required. It's purely just a gradient. Tissue diffusion we spoke about, right? CO2 going from the cells to the interstitial fluid, back into the bloodstream to be delivered back to the lungs, and oxygen leaving the blood, leaving hemoglobin as well, going into the interstitial fluid and then into the cells to maintain oxygen levels in the cells for cellular metabolism. Okay, perfusion purely just flow of blood to an organ. So if we say pulmonary perfusion, blood flow through the pulmonary vessels. That's it. Tissue perfusion just means, are your tissues being perfused? You can choose any organ and put the word perfusion beside it. Cerebral perfusion, blood flow in the heart, in the brain. Coronary perfusion, blood flow in the heart. Renal perfusion, blood flow to the kidney. Okay, remember that because what affects perfusion to the lungs? Typically, we're concerned about a pulmonary embolus. Okay, if there's sudden decreased perfusion of blood to a lung segment. Okay. Okay, so we're just going to move on a bit and just talk briefly about a health history and physical assessment of the respiratory system. So a health history is important, right? I mean, if someone comes in short of breath, we want to know, do you have a history of asthma? Are you a long-term smoker? Do you have allergies that affect your respiratory system? So environmental allergies. Are there other people in your family that have had lung issues? So a health history in terms of the respiratory system is really focusing on past medical history that may impact your lungs and causing your symptoms today. Okay, so we really kind of hone in on certain conditions like asthma, COPD. Typically, we would know if someone has cystic fibrosis. Um, it's usually diagnosed in childhood. Okay. Other health history. Have you had fevers? Have you been coughing up phlegm chronically for years? That would make us think, okay, if you've been chronic, if you have chronic phlegm production, and you're frequently short of breath, and you have a chronic cough, we're thinking COPD. If you have recurrent bouts of wheezing, shortness of breath that then go away and come back um, repeatedly over years, we're thinking, okay, this person might have asthma. Okay. So the physical assessment of the respiratory system, will go into some symptoms and signs of that on the upcoming slides. Okay, so these would be symptoms. So here's a health history that we're asking about, where we're trying to focus on the respiratory system. So we may want to know your recent health history and your recent symptoms. So are you short of breath? Do you have difficulty getting air into your lungs? So inhaling, or difficulty exhaling? Are you coughing now? If you are coughing, are you coughing up any phlegm? Do you have chest pain? Say with your breathing. Does it hurt to take a deep breath? If it hurts to take a deep breath, we call that pleuritic chest pain. And pleuritic chest pain can be an indication of something that's irritating the pleura as the lungs are expanding and stretching the pleura. And the most concerning one for that would be a pulmonary embolus, right? So pleuritic chest pain during inhalation. Are you wheezing? Do you have expiratory wheezing? Okay. Do you have difficulty getting air out? Have you coughed up any blood? So if you've coughed up blood, we're starting to think of, is there a possibility of lung cancer? Sometimes in tuberculosis, you can cough up a bit of blood. Okay. Dysphagia is, are you having any problems swallowing? Does the food go down normally, or does it feel like it's getting stuck? Okay. So dyspnea, just a fancy word for shortness of breath. If someone says they're coughing, we'd want to know how long, how frequent. Is it nighttime? Is it throughout the whole day? Sputum, what color? Is there blood in it? Is it kind of a greenish color? Or is it just clear phlegm? Chest pain, when? Is it when you take a deep breath? Okay. If that's the case, we might be thinking of pulmonary embolus. Wheezing, okay. Is it wheezing during exhalation? We're thinking, could this person have an asthma flare-up? Could they have COPD? Hemoptysis? We don't like to hear hemoptysis. That can be an indication of lung cancer, TB. Sometimes you can get it with pulmonary edema as well from congestive heart failure. Okay. Past medical history, I mentioned just, do you have a previous history of COPD, asthma, breathing issues? And we would ask that in terms of, do you have a family history of any asthma or respiratory issues? Okay. Okay, so physical assessment of the respiratory system. So one of the most useful assessments is just looking. Just look at the person. Are they breathing fast? Are they holding onto a table, splinting themselves because they're so short of breath? Are they sweaty? Do they look fearful? Are they using accessory muscles, meaning the muscles in their neck are being used to help inhale? Do they have indrawing, meaning every time they take a breath, the intercostal spaces collapse inwards, and that's because there's so much negative pressure during inhalation because there's something wrong with the system, that the intercostal muscles are actually caving inwards. That's called indrawing. Okay, so um, so looking is really, really useful. Okay, are they cyanotic? Okay, do they have a bluish tinge to their lips? Do they have blue fingernails? Um, not from makeup or not from nail polish, just do they have blue nail beds? Uh, Clubbing is more in chronic conditions. Okay, so the term clubbing of your fingers, you can see an image there of just excessive tissue forming at the distal fingers, and the shape of the nail itself is curved. That's from chronic lung conditions and chronic heart conditions. So a child that has a congenital heart disease, so they have a hole in their heart, like a ventricular septal defect, or they have some kind of cardiac anomaly where they're chronically hypoxemic, they could have clubbing. In terms of lung conditions, cystic fibrosis, that's a chronic condition where patients often have chronic hypoxemia, that can lead to clubbing. Lung cancer can lead to clubbing. Sometimes, not very often, COPD, chronic obstructive lung disease, can lead to clubbing. Okay, so think of clubbing as a long-term respiratory condition or a chronic heart condition that's leading to hypoxemia. Okay, so for example, someone who has asthma, we don't see clubbing in patients with asthma. Okay. Okay, so upper respiratory structures. I'm going to tell you this one's going to depend on which textbook you look at, but typically the cutoff for upper and lower respiratory structures is the vocal cords. So that's the larynx. So upper respiratory structures should be the nose, the mouth, the sinuses, the pharynx, which is the back of your throat, and the larynx, which is your voice box, where your vocal cords are. Okay? Lower respiratory structures, trachea, the bronchi, so the left and right main bronchi, the bronchial tubes, okay, the smaller tubes, and then finally the lungs and the alveoli. That's your lower respiratory tract. Okay, so if we say someone has an upper respiratory tract, well, that could be laryngitis, so inflammation of the vocal cords. That could be pharyngitis, so say a viral infection in the back of your throat or strep throat. That could be sinusitis. That would be an upper respiratory tract infection. What about lower respiratory tract infections? Well, that could be a bronchitis. How about asthma? That affects your bronchial tubes. Pneumonia, cystic fibrosis, COPD. Those are lower respiratory tract conditions. Okay. Now, when we're looking at someone in terms of physical assessment, positioning is important. Okay, so how is the person positioned themselves? Are they lying back in a bed, comfortable, breathing just fine? Or are they leaning forward and holding on to a table because they're so short of breath and they're trying to splint themselves? Okay. Thoracic inspection is just using your eyes. Okay. Are they breathing at 40 per minute, which is terribly fast? Or are they comfortably breathing at 16 per minute? When the chest wall is expanding, are they having to use accessory muscles? And are the intercostal spaces indrawing when they breathe? That's just inspection. Do they have a barrel chest of COPD, kind of a large, overinflated chest? Auscultation is just listening with a stethoscope. Do they have normal air entry bilaterally? Or do they have expiratory wheezing of COPD or asthma? Do they have inspiratory crackles or crepitations in a certain area of a lung, such as in pneumonia? Do they have bilateral crackles at the bottom of their lungs and crepitations which could be pneumonia on both sides, or pulmonary fibrosis. So scarring of the lungs can do that. Okay. In terms of palpating, or what we call percussing, so tapping on the chest on each side, um, the lung should sound resonant when you tap it. So if it's dull when you tap over a certain part of the lung, that usually means there's something blocking the that normal resonant sound. So what could do that? A pleural effusion, so fluid that's blocking the normal resonant sound. Or how about a pneumonia in that area that's giving you dullness to percussion? So pleural effusion, pneumonia can give you dullness to percussion. What about hyper resonance when we're percussing? So if it sounds like when you tap on someone's chest that just sounds like a hollow cavity, that's usually pneumothorax. Okay? So when we tap on someone's chest, it should be resonant because the lungs are filled with air. It shouldn't be dull, such as in pneumonia and pleural effusion, and it shouldn't be hyper-resonant, such as in a pneumothorax. Okay, so I'm going to start to speed up in the interest of time because I don't want this to turn into a 6-hour session for you. So adventitious breath sounds are just extra sounds that we're hearing in the lungs. Normally, we should just hear normal air entry to both lungs. But we listen to the lungs trying to see if there's sounds that shouldn't normally be there. Okay, so crackles. So crackles can occur in, say, heart failure. So there's fluid in the lungs that's backed up from the left side of the heart. And you can have crackles. And typically it's on both sides because the fluid is on both sides. Okay. You can have crackles from pulmonary fibrosis because the lungs are all fibrotic. So when they expand, you can hear all this crackling. Okay. You could have focal crackles, meaning just one part of the lung has some crackles in it, and that's usually an indication of pneumonia. Okay. As the alveoli are opening during inspiration, they're popping a bit because they're partly filled with fluid from infection. Okay. I would give the analogy of crackles when you pour milk over Rice Krispies. That's what it sounds like. Okay, they're cracking and popping a bit. Wheezing is really common in asthma, especially expiratory wheezing. Okay, it also happens in chronic obstructive lung disease. You can have wheezing, especially expiratory wheezing. Now, you could have wheezing in one part of your lung if there was something blocking that particular segment of the airway, of the bronchial tube. So say you have a lung tumor there that's blocking the airflow there. You could have focal wheezing. Okay, but wheezing in general, we think of asthma and COPD. What about a friction rub? So a pleural friction rub is where we hear the two layers of the pleura. You shouldn't normally hear this at all, but when someone's inhaling, if there's inflammation in the pleura, such as in pleuritis, which is just inflammation of the pleura, typically from a viral infection, and patients say, well, it hurts for me to take a deep breath, and we hear a pleural friction rub, that's the two layers of the pleura rubbing against each other, making that sound. Okay, so, and it usually means that there's inflammation there. So a pleural friction rub can occur in pleuritis. It could occur, say, from a pneumonia that's touching the pleura and causing inflammation of the pleura, and we hear it as a rub. And it's painful, right? Because the pleura is expanding during inspiration, and the patient says, this area really hurts when I take a deep breath. Okay, so wheezing, so that's narrowing. So typically it's from narrowing of the bronchial tubes. What causes that typically? Asthma and COPD. from bronchoconstriction and um, excessive mucus production. So where does wheezing come from? Bronchial tubes and the narrowing of them in particular. Crackles, where do coarse crackles come from? Well, it can come from pulmonary edema, so that's from congestive heart failure typically, where you have backup of fluid into the lungs. You can get crackles from a pneumonia. Okay, so if we hear crackles in just one segment of the lung, we might suspect, oh, this person might have a pneumonia right there. Pulmonary fibrosis is a chronic condition where the lungs are gradually just becoming more and more fibrotic, and we often hear crackles in someone with pulmonary fibrosis, and it's usually kind of spread throughout the whole lungs. Okay, so I won't have much or anything on this slide since we're still on chapter 17, and I've done the questions for chapter 17 in ATI, so we can just move on. Okay, so respiratory diagnostic procedures. And at the top of this module, I did talk about some of these, and we're going to go into them in more detail. I think the only one I didn't mention was the top one, pulse oximetry. So what's pulse oximetry or O2 saturation? It's putting a monitor typically on someone's finger, but we can use a toe, we can use an earlobe. Often we have to take nail polish off, okay, because it blocks the O2, the pulse oximetry from reading. And what's it telling us? It's telling us the amount of hemoglobin that is saturated with oxygen. So remember that an O2 saturation or pulse oximetry is telling us the amount of hemoglobin that is saturated with oxygen in the blood. Okay. The other ones I mentioned briefly, so we'll move on and talk about them. Okay, so pulse oximetry or O2 saturation monitor. As you can see, it's a monitor that easily just clips onto someone's finger. In the bottom left, you can see that there's, we often use those in children. We can wrap that around a finger. We can put it on an earlobe. Anywhere we can get a good pulse because it's picking up the heartbeat, and then it's going to interpret the oxygen saturation. Okay. So if there's not a good pulse at the area, if we're not picking up a good pulse, say at someone's fingertip, it's not going to give us an accurate O2 saturation or pulse oximetry. Carbon monoxide poisoning. So say someone's been in a house fire and we're doing an O2 saturation, it can be deceiving. It can be high or normal because carbon monoxide attaches to hemoglobin, and it could give us a false sense of security, okay? Because it's going to say O2 sat of 98%, when in actual fact, the hemoglobin has carbon monoxide bound to it. So we can't rely on a pulse oximeter for carbon monoxide poisoning and the amount of oxygen that's attached to the hemoglobin. Hypovolemia, well, why wouldn't it work really well? Well, it wouldn't work well because we're not going to have a great pulse. So it's back to the first reasoning. The poor picking up of the heartbeat is going to result in an inaccurate O2 saturation. Okay, where can we put it? Basically anywhere to try and pick up that pulse. So fingers, toes, we can tape it on the forehead, earlobes. Don't usually use lips, but you can try it there. So all over the place to try and pick up an O2 saturation. Pulmonary function tests. So that's where we have someone sit in front of a machine that has a tube coming out of it, and we get them to take deep breaths and blow forcefully into the machine. So it's going to tell us the volumes of the lungs. So who would we get this test on? Well, say someone comes in with shortness of breath, but we're not really sure of the cause. And we're trying to determine if it's COPD, if it's asthma. So we can use it on someone with dyspnea to try and help us diagnose the underlying cause. Remember, a chest x-ray doesn't always help us determine what the cause of shortness of breath is. If the chest x-ray is normal, well, the patient could still have some degree of COPD, they could have some asthma that's not showing up on a chest x-ray, okay? Pre-surgical patients, if there's a concern about breathing before someone undergoes a surgery, well, pulmonary function tests are going to be done because it'll tell us the exact volumes and ventilation of the patient. So if someone's undergoing a large surgery, pulmonary function tests are often done to see that this person has normal lung volumes. Okay. No smoking prior to the test, typically 6 to 8 hours. Why? Well, smoking is an irritant to the lungs, and it can give us inaccurate readings of the pulmonary function tests. In fact, patients are often advised to stop smoking for 2 weeks prior to surgery, if possible, because your lungs actually improve in that 2 weeks of having not smoked. Okay, so they're strongly encouraged not to smoke prior to surgery. No inhalers prior to use because inhalers can bronchodilate, and it's going to give us an inaccurate pulmonary function test of how the person's real lung volumes are without medication. Okay, so no smoking and no inhalers prior to the pulmonary function test. Okay, so this slide's just giving us a bit of a readout of pulmonary function tests. So let's just talk about a couple of terms first that we get with a pulmonary function test. Remember, you're sitting in front of a machine and you're blowing into this tube that goes into the machine, and it gives us lung volumes. Okay, so a tidal volume is really just the patient sitting there and breathing normally. How much air is going in and going out with each breath without breathing faster or harder, just what's the tidal volume. Okay, so just the total volume, just the volume going in and out with each breath. Vital capacity is taking the biggest breath you can, holding it and breathing it all the way out, as much as you can breathe out. Okay, that's vital capacity of your lung. Now, even at the end of expiration, so you've breathed out as hard as you can, you still have a bit of air left in your lungs, and that would be called your residual volume. Okay, so let's go to the right here and just look at this at the top, some readout here. So forced vital capacity is just what we just spoke about, vital capacity. How much air did you force out? Okay, right down to complete exhalation. Okay, and then the machine will decide, okay, was that the expected amount of lung volume for your size or not? And it'll give a percentage of what was expected and what was your best forced vital capacity. Forced expiratory volume in 1 second, FEV1, is how much air did you blow out in the first 1 second. Why is that useful? Well, what about an asthmatic? They can't blow out air very fast because they have bronchoconstriction. So they can't get all of their vital capacity out quickly. So their FEV1 is going to be reduced because they can't get that air out fast, right? Because of the wheezing and the bronchoconstriction. Okay, so these are just giving us lung volumes and what's expected and what's actually occurring, and then it helps us diagnose. Is this asthma? Is it COPD? Is it pulmonary fibrosis? Okay, that's all it's doing. Okay, so I think remembering that pulmonary function tests are measuring lung volumes and also lung volumes over a certain time, such as 1 second. So how much of your total vital capacity can you get out in 1 second? Well, that's your FEV1. Okay. Okay, so let's talk about arterial blood gases. So that's the procedure where we're going to obtain arterial blood gas, typically from the radial artery at the wrist. Okay, it's an accessible artery, and typically we want to get arterial blood to really get an accurate evaluation of what's happening on the arterial side of the systemic circulation. So we're going to get a pH, we're going to get a PaO2, we're going to get a PCO2, we're going to get a bicarb level, and all those values are going to give us information about, typically we're using this for respiratory conditions, someone who's really short of breath, and we want to see if they're acidotic. We want to see what the partial pressure of oxygen is in their blood, and we want to see the CO2. Are they able to clear the CO2 from their lungs, or is it building up in the blood? Okay. Sometimes we'll use it in diabetic ketoacidosis because those patients can become really acidotic. So we want to see what the arterial pH is and the other values as well. Okay. We can use it for someone on a mechanical ventilator to see if we need to adjust the dials on the mechanical ventilator. Do we have to make the machine breathe faster for them? Do we have to make the machine give them deeper breaths, so increased volumes to the patient? And we can adjust the mechanical ventilator based on the arterial blood gas. Okay, so there's definitely some patient education here because we're going to poke an artery in the wrist, and it's painful, it hurts. Okay, so we tell them about the procedure and why we need to obtain an arterial blood sample. What are the complications? Well, this radial artery is under pressure. So when we stab it, when we do an arterial stab, we can create a hematoma under the tissue there, right? Because when we take the needle out, the radial artery can leak a bit and cause a hematoma. An air embolus is where we mistakenly put air into the artery. That's pretty uncommon with this procedure, but it's possible. And lastly, the radial artery has been injured and it becomes occluded. Okay, and that's why we do a test to evaluate the circulation to the wrist, to the hand first. And that test is called the Allen's test. Okay, so there's two arteries going to your hand, the ulnar and the radial artery. So we press them firmly. This is before the test. We press them firmly and we get the person to clench their hand. And when they open the hand, it's white because we've blocked the artery, both arteries, from getting blood to the hand. And then we release the ulnar artery and the hand goes nice and pink again. So that means that the ulnar artery is working properly. It's allowing blood flow to go to the entire hand. Why do we care? Well, because we could potentially injure the radial artery with this test. So we want to do an Allen's test to make sure that if that were to happen, is the ulnar artery able to supply blood to the hand? Okay, so that's the reasoning for the Allen's test. Now, when we get the sample, so when we get into the artery in that syringe, let's start at the beginning. We clean the area very well, so sterilely. We clean the area of the wrist. Okay, so that's called the ventral side of the wrist. Okay, so we clean the area well. We feel for the artery. We insert the needle into the artery, and immediately blood will fill that syringe. Once we get it, that has to be taken directly to the lab to be processed. If it sits in the syringe for for minutes or even half an hour, say, it's useless because the pH and the oxygen and the CO2 have changed in the sample. So it has to be processed immediately. Okay? And we don't want to do it again because it's a painful procedure. So after the procedure, what do? We hold that area for 5 minutes. Okay? And then we maintain the pressure even longer if someone is on an anticoagulant, okay? Because we don't want them to form a hematoma, okay? Now, and then we get a readout of the arterial blood gas that we'll talk about on an upcoming slide, okay? Okay, so now we've taken the sample to the lab and the machine has interpreted the values for us. Or not interpreted, it's processed the values for us. We have to do the interpreting. So arterial blood gas, what are we going to get? We're going to get a pH. Okay, pH should be between 7.35 and 7.45 in a human. So if it's lower than 7.35, acidosis. Higher than 7.45, alkalosis. We really want to see pH because if someone has a respiratory condition where they're really short of breath, they may have respiratory acidosis. If we're doing this for, say, diabetic ketoacidosis, they could be very acidotic because of all the acids that have being built up in the bloodstream from the diabetic ketoacidosis. So pH is really important. Okay, pH is telling you the amount of hydrogen ions in the bloodstream, and the more hydrogen ions, the lower the pH. And as your pH goes down from 7.35, 7.25, 7.1, and lower, the patient's going to get sicker and sicker and sicker. Okay, there's many metabolic processes that can't work as you become acidotic. Okay, so the lowest pH I've ever seen with someone who is still alive was 6.8. Okay. That's starting to become non-compatible with life, okay? A PaO2, well, that's just measuring the pressure that we spoke about before of oxygen in the bloodstream. That's not telling us anything about the hemoglobin, just how much oxygen is in the bloodstream that the alveoli delivered to the blood, okay? And usually that's 80 to 100. Okay, partial pressure of CO2. Okay, and this is an arterial sample, so we're expecting it to be a lot of the CO2 went into the alveoli, so we want to see that it's at a certain value of 35 to 45 on an arterial blood gas. Bicarbonate should be between around 21 to 28 or 22 to 26 in that range. And bicarbonate is your buffering system. So if your bicarbonate is low, it usually means that it's being used up by an acidosis, by some condition that's making your body acidotic. And lastly, the SaO2 is just the amount of oxygen that's bound, so the percentage of hemoglobin that's bound with oxygen. That's it. Okay? So SaO2 or O2 saturation or pulse oximetry, we're getting an SaO2 on the arterial blood gas, okay? But they're all similar in terms of whether we call it an O2 saturation or an SaO2. It's just O2 saturation of the hemoglobin with oxygen, okay? Let's just look at the top part of those values on the left there, okay? Blood gas values. I'm not going to do any of the other ones. Let's just look at that one. Okay, so the pH is 6.9. Okay, I already mentioned that, as you approach 6.8, 6.8, the person is deathly ill. 6.9, you're really, really sick. Okay? From whatever's causing the illness, a pH of 6.9, you're going to be incredibly ill. Okay, let's go to the next value. So we know the pH is low. The PCO2, so the amount of CO2 that's in the blood, That should be 35 to 45. It's 155. That's immediately telling us this is coming from the lungs, because the lungs are what clears your CO2 and maintains normal CO2 levels in the blood. So a PCO2 of 155, you know this is a respiratory acidosis. You're done. Okay? So blood gas values don't have to be hard. If you see a low pH and a high PCO2, you're done. Respiratory acidosis. Okay? We'll spend a bit more time on the upcoming slides. Okay, so we have the values from the machine after doing um, a obtaining an arterial blood gas from the radial artery. Okay. By the way, patients don't want this done very frequently because it's painful. Okay, and we don't want to do it very frequently because it's painful and there's potential complications. Okay, so let's look at the left here. Normal values. Okay, pH we've spoken about. PCO2 we've spoken about. Bicarb 22 to 26 in this example. Okay. Okay, so what if the acidosis is coming from pneumonia or asthma or COPD, and your lungs are not able to clear the CO2? Well, the CO2 is going to back up in your bloodstream and it's going to produce hydrogen ions. Remember, CO2 plus water, H2O, is in equilibrium with HCO3 and H+. H+ is what's deciding your pH. So if you have a respiratory acidosis, meaning there's something wrong with your lungs where you can't clear the CO2, it's going to produce more hydrogen ions. It's going to lower your pH. So you're going to have a low pH, less than 7.35. You're going to have an elevated PCO2 because that's what's causing the problem to begin with. And your bicarb is typically going to be normal. Okay? So what can cause this? COPD flare, pneumonia, asthma flare. Say someone's been given too many opioids and they're not breathing, they're not ventilating properly, so they're not able to clear their CO2. It's going to build up and lead to excessive H+ ions, respiratory acidosis. Respiratory alkalosis, well, that's typically just from breathing too fast. It's typically anxiety or pain that's doing that. Your pH is a bit on the high side, so above 7.45. And the reason why it's a respiratory alkalosis, just look at the CO2. You're breathing it off too fast because you're either anxious or you're in pain. So you have a low PCO2 because you're breathing off the CO2, and that's raising your pH. It's getting rid of hydrogen ions. Metabolic acidosis, your pH is going to be low just by definition of acidosis. Your PCO2 is normal because it's not a lung problem. Your bicarbonate is being used up because that's the buffering system in the blood. So it's going to be lower. So a low pH with a low bicarbonate, metabolic acidosis. What can cause that? Diabetic ketoacidosis, a shock state with hypotension where your tissues aren't being perfused, but they're still performing their metabolic activities, and that produces hydrogen ions. So just your general metabolism produces hydrogen ions as a byproduct. So if you're not perfusing and able to clear the hydrogen ions, such as in a shock state or like hypotension, you're going to become acidotic. Or in renal failure. So your kidneys produce bicarbonate, and on top of that, they secrete or excrete hydrogen ions. So if you have severe renal failure, you're going to develop metabolic acidosis. Low pH, low bicarbonate. Okay. Metabolic alkalosis is extremely uncommon. That would be a high pH, okay, alkalosis, from a metabolic condition. Well, that's typically from just taking too much, say, of an antacid. So bicarbonate is an antacid. Or say you're vomiting profusely. Well, when you vomit, you actually vomit up hydrogen ions. You're getting rid of acid, and your body's having to replace that acid. But your blood is becoming alkalotic because you're getting rid of hydrogen ions. Okay, so vomiting or NG drainage basically is the same as vomiting. You're just sucking up hydrogen ions from the stomach. Okay. So if you understand that, if you go to the slide on the right, or the image on the right, um, uh, uncompensated, partially compensated, fully compensated. Let's just talk about that briefly. So respiratory acidosis, those are the three common conditions: asthma, pneumonia, and hypoventilation on the right there. They can all lead to a buildup of CO2 and then lead to respiratory acidosis. Okay, so if it's uncompensated, well, it's going to be a low pH and a high CO2. If it's partially compensated, it's just telling us that, okay, it's improving, the pH is improving, it's getting higher, maybe the CO2 is getting lower, but it hasn't returned to normal yet. So a partially compensated means that your pH is still on the low side. It hasn't fully compensated. Fully compensated means your pH has returned to normal, but your CO2 is still elevated. But a fully compensated respiratory acidosis means that your pH has returned into the normal range, despite still having an elevated CO2. And how did that happen? Well, your kidneys started to make bicarbonate to get rid of some of the hydrogen ions. Okay? I'm not going to go through each one of these. Just understand the concept of the fact that partially compensated means that your pH hasn't fully returned to normal, whether it's acidosis or alkalosis. Okay, and it'll make sense for each one. Let's just look at metabolic acidosis, because that's a common one with DKA. So uncompensated, your pH is low. Your CO2 is irrelevant because it should be normal, because it's not a lung problem. And your bicarb is low, so bicarb HCO3 is low. Why? Because your body is using it up to try and buffer all this hydrogen ion. Okay. Partially compensated, your pH is still low, hasn't returned to normal yet, and your bicarbonate is still low, but typically they're improving. Okay, so sometimes it's really hard to tell when you're just given one blood gas. Often we have 3 or 4 blood gases that we can compare them to. Fully compensated, again, the pH has returned to normal. So I'm not going to use this slide for questions, but I just want to tell you, remember those 3 buffering systems of the body, right? So you have your serum buffers, which are constantly there, which is bicarbonate, that can soak up some of the hydrogen ions. You have and that's a fast acting. Your serum buffering is the fastest system. Then you have your respiratory system to blow off CO2. When you blow off CO2, you're actually making hydrogen ions combine with HCO3, and it turns it into H2O and CO2 that you can breathe off. Okay, that's your second buffering system. And your third buffering system that takes sometimes hours to days to really become fully effective is your renal system. So your kidneys are able to produce bicarbonate, and a lot of bicarbonate, to buffer the system even more. And on top of that, the kidneys can excrete hydrogen ions. So those are your 3 buffering systems to maintain normal pH. Okay, and normal pH is critical. Acidosis is a deadly condition. Okay, so the body really wants to keep the pH between 7.35 and 7.45. Okay, so let's talk about bronchoscopy. So it's basically a camera going into the mouth and then into the trachea to visualize an area of concern. Okay, and it has the ability to actually biopsy the area as well. Okay, so in this image on the left, you're seeing a flexible bronchoscopy and a rigid bronchoscopy. That's it. That's the only difference between them. One has a flexible attachment and one has a rigid attachment. Okay, so it's going into the trachea and the upper bronchial tubes to visualize and potentially biopsy an area of concern, such as lung cancer, or maybe an area of inflammation or of narrowing that we just don't know what the cause is yet. Okay. It can also take secretions in the bronchial tubes. It can suck up some secretions and send them off for a culture if we think there's some kind of infection occurring. It also has the ability to remove a foreign body. So, say you aspirated a chunk of chicken and it's stuck in your trachea or your bronchial tube. Or say a child inhaled something metal into their trachea, or it's stuck in a bronchial tube. They can use a bronchoscopy to go and get it. Okay. It can also be used to remove complete lesions. So not only to biopsy it, but while you're there, you could try and remove a small lesion. So it's used for diagnostic purposes, so diagnosis of a lung cancer and getting a biopsy of it, or for therapeutic, such as removing a foreign body that's stuck in a bronchial tube or one of the larger bronchi. Okay, so typically for this procedure, most of the time it's done as an outpatient if you're not in hospital. But I mean, if you're in hospital, okay, take you down to the surgical suite and do the bronchoscopy. But you could be an outpatient and just go for a bronchoscopy and go home the same day. Okay. So typically for a bronchoscopy, dentures are removed. The patient receives some anesthesia and some analgesia, and they're typically NPO prior to the procedure. Okay, so no eating prior to the procedure, usually 4 to 6 to 8 hours prior, just in case they vomit up their stomach contents. Okay. So the patient receives sedation. They're given an anesthetic. Okay, so a painkiller. So what kind of anesthetic can we use? Well, an injectable opioid such as fentanyl. What's sedative? Well, we could use propofol. We could use diazepam, anything to sedate the patient a bit. Okay. The back of the throat is often sprayed with some lidocaine to freeze it. Sometimes atropine is used to dry up secretions in the mouth and in the trachea. Okay. Patient is kept in an upright position. Sometimes they can remain flat, but often they're sitting up in bed. Okay. The patient's going to be on a monitor for vital signs. O2 saturation is going to be monitored for the entire procedure because you have a bronchoscopy in your trachea. What's going to happen post-procedure? Well, there's going to be continuous monitoring still, right? So monitoring of respirations, blood pressure, O2 sat is all going to be important after the procedure. Now, of course, before drinking or eating, their level of consciousness has to return to normal. The presence of a gag reflex has to be there. Okay. Otherwise, there's a risk post-procedure of aspirating. Okay. So there needs to be some time for the normal cough reflex and gag reflex to return. Now, can we expect a sore throat, a bit of a cough, maybe a bit of bloody sputum after the procedure? Absolutely. Okay, that would not be unexpected. It can happen. Do we expect someone to have wheezing, bronchospasm, where they're acutely short of breath? Definitely not. Okay, that shouldn't happen. So bronchospasm or laryngospasm, meaning your vocal cords are really irritable and they're opening and closing by themselves, we wouldn't expect that. Okay, and that would be concerning. So the complications of a bronchoscopy. So one of them would be laryngospasm because the tube went right through the vocal cords, right, like right between them. So that's contraction of the vocal cords and it's uncontrolled. Well, you need your vocal cords to cooperate in order to get air into your lungs. So if you go into laryngospasm, that can be an airway emergency. Okay. A pneumothorax, that would be pretty uncommon, but there is a potential, especially with a rigid bronchoscopy, to actually poke through a bronchial tube and potentially perforate a lung or create a pneumothorax. Uncommon, but it's possible. If we thought that happened, we would do a chest X-ray looking for pneumothorax. Aspiration is a risk, right? So, and that's why they're observed after the procedure, and fluids are withheld until their gag and cough reflex returns, which usually takes a couple of hours. Okay, so here's some images of a bronchoscopy. So what are some complications? Well, you could be allergic to one of the medications. That's always possible with any medication we give. Over sedation, so it's taking you longer to wake up post-procedure. That's definitely possible. Infection, sure. You've had a foreign object inserted into your trachea, which really there should never be a foreign object in your trachea. So potential for infection. Aspiration we spoke about. Sorry. So aspiration of oral secretions, or even worse, you vomit and you aspirate the vomit into your lungs. Lungs really don't like acidic vomit. They get really inflamed from it. Okay, so aspiration is a big issue. Laryngospasm or bronchospasm we spoke about, that's a risk factor and that can become an emergency. Pneumothorax, unlikely. You'd have to perforate, you'd have to punch, you had to go through a bronchial tube and actually collapse the lung, so unlikely. Bleeding, so profuse bleeding can happen. A bit of bleeding after procedure is not uncommon because often biopsies are taken. Okay, let's look at the images on the right. So there's a normal looking bronchial tube. So looking downwards, sorry, that's the trachea, and at the bottom you're seeing the two main bronchi split off. Lower left, there's a foreign body in one of the main bronchi. That can be removed since there's the ability with a bronchoscopy to remove foreign objects. And the image on the right is a bronchial carcinoma. Okay, so let's move on. Okay, on to another procedure where somebody has, say, a pleural effusion or a collection of some kind of fluid in the pleural space. So it's not in the lung, it's in the pleural space. And we want to remove it to either diagnose what the fluid is or to relieve the person's symptoms of shortness of breath. Okay, so the needle is not going into the lung, it's going into the fluid in the pleural space. Okay, so typically we're going to use a relatively wide bore needle so that it doesn't get plugged up if it's a thick fluid, and we usually go in through the back. So you can see this patient is well, has their shirt off, obviously. They're leaning on a counter or a desk, a bedside table, and they have their arms on a pillow, leaning forward, and that's the perfect position. Now, usually we're going to exactly localize the fluid with an ultrasound machine at the bedside, and then we can mark off the area where we want to go in. Okay. After that, we're going to fully freeze the skin and the tissue below until we get right to the pleura, because the pleura is incredibly painful if we don't freeze it first. And then we're going to insert our needle that's attached to a syringe, and we're pulling on the we're giving some negative pressure to the syringe, so that as soon as we get into the pleural space, fluid will come rushing into the syringe. Okay. So now, why is this helpful? Well, for diagnostic purposes, we can take pleural fluid and we can send it off to the lab. Okay. What is it? What is that? If it's for diagnostic purposes, meaning we don't know why this fluid's here, we're going to send it off and find out. Well, how's that going to help? Well, we can distinguish between what's called a transudate, which just means that for some reason fluid is coming out of the blood vessels and leaking into the pleural space. So sometimes that can, in pleural effusions, that can happen with heart failure, cirrhosis because you have low albumin, renal issues such as nephrotic syndrome or nephritis. Why? Low albumin. Okay. An exudate is a condition usually from inflammation, and we know with inflammation the blood vessels get leaky on purpose, right? So any kind of inflammation in the area, or infection in the area that's causing inflammation, or a neoplasm, which is cancer, which is causing inflammation, will create an exudate. Okay, it's still fluid. It's just what's in the fluid will be different compared to a transudate. An empyema is a collection of pus. Okay, so if we were to suck back on the syringe and we got all pus, that's an empyema, and we would send that off for a culture and sensitivity. Okay. Sometimes we'll do a thoracentesis if someone's had some kind of chest injury or a very forceful blow to the chest, and we can see that there's a collection of fluid, and we'll do a thoracentesis to see if it's just a clear fluid collection, like a pleural effusion, or if it's a hemothorax, meaning there's blood in the pleural space. Okay, so what does someone sound like that has a pleural effusion? Well, if we were to listen to them, they would have reduced air entry there. Okay, so reduced air entry on auscultation. If we were to percuss them there, they would be dull to percussion because there's fluid there, so it has that dull sound. Okay. Now, in your book, it's mentioning interpretation of findings. I'm not going to go into this in too much detail, but it's going to say the general appearance of the fluid. Sure, if it's nice, it has a nice clear yellow appearance, that's classic for a pleural effusion. If it has obviously a red appearance, okay, could be a hemothorax. If it comes out as pus, that's an empyema. And then we send it to the lab to be analyzed, and we send it for cell counts, so white blood cell count. We send it for, is there a lot of protein in the fluid, and is there glucose in the fluid, okay? We also send it for a culture and sensitivity to see if there's any bacteria growing. And all of these tests will help us determine what the fluid is from. Okay, so is it a transudate? So a transudate doesn't typically have a lot of protein in it, because a transudate, there was no inflammation. It was just fluid that came across the capillaries into the area, such as in congestive heart failure or someone with low albumin. So they're not leaking protein into the area. That's a transudate. So a transudate doesn't have a lot of protein. So if someone says, I have a transudate in my pleural effusion, that's usually from congestive heart failure or cirrhosis, or some kind of kidney condition where they're losing protein and they have leaky vessels. That's a transudate. An exudate is more, you have some kind of infection or inflammation in the area. So it just helps us determine when we send the fluid off to examine it. So under pre-procedure, so I mentioned the procedure to you, and we definitely tell patients exactly how to position themselves, leaning forward on a pillow, on a table, and to keep as still as possible. And that's one of the main reasons why we anesthetize the area with local anesthetic. because we don't want them jumping around while we're putting a needle through into the pleural space. Okay. So we anesthetize it really well, and we tell them if there's any pain, just let us know, and we can put more freezing in. Okay, so to keep really still during the procedure, minimize any coughing or talking or anything like that. Okay, so this is a sterile technique because we don't want to introduce bacteria into the lungs. Okay, we get the needle ready. We have the patient on a monitor for vital signs and oxygen saturation, and we slowly go through the skin and then into the intercostal space and then into the pleural space and aspirate fluid. Okay. Post-procedure, we apply a dressing, so a sterile dressing to the site. That's really important. We still monitor vital signs, blood pressure, heart rate, O2 saturation, since we've gone into the pleural space. We're going to listen to the area to make sure we haven't caused a lung collapse. We typically get an x-ray after the procedure to make sure that we haven't collapsed the lung, we haven't caused a pneumothorax, because that sharp needle could have touched the lung, leading to a pneumothorax, right? So the biggest, I would say the most common complication is a small pneumothorax from this procedure, where we just poked the lung and the lung collapsed. Okay, so what do we get from that? Diminished breath sounds on that side. Now, if it turned into a tension pneumothorax, which would be really uncommon, but any pneumothorax can turn into a tension pneumothorax, well, now not only are you into diminished breath sounds, but now you're into increased pressure on that side of the thoracic cavity, so it's going to cause distended neck veins. It's going to cause the mediastinum, so your heart, to move over to the other side. It's going to cause hypotension. The patient's going to be in distress. They're going to be tachycardic. So think of a pneumothorax as just, okay, one of the lungs has collapsed to a certain extent. A tension pneumothorax is actually a complication of just your run-of-the-mill pneumothorax, where pressure builds on that side and it gives a whole lot more symptoms. Okay, distended neck veins, tachycardia, mediastinal shift, tracheal shift to the unaffected side, still decreased breath sounds on that side, of course. Okay, so tension pneumothorax is really serious. Okay, so we tell patients about signs of watching out for a pneumothorax. So if you're more short of breath, you need to return and let us know. Okay, bleeding at the site of the procedure, that's not uncommon. That can happen a bit. Shouldn't be profuse bleeding, but a bit of bleeding is okay. Now sometimes when we've taken the fluid out, what's a complication? Well, we're re-expanding the lung into that area because we're taking fluid away. So patients often have some coughing afterwards. Okay, after the procedure, they're coughing. Okay, infection, of course, because we've put a needle into the pleural fluid, we're running the risk of an infection. But we do it sterilely, so it's usually safe. So, thoracentesis complications, infection, pneumothorax, usually a simple pneumothorax, not a tension so much, but it's possible, and bleeding. So outer bleeding on the skin, not a big concern, but if we hit an artery or a vessel inside the chest, that could be internal bleeding, leading to hypotension and reduced hemoglobin levels. That would be much more serious. Okay. Okay, we'll go through this slide quickly since we've already spoken about it. So considerations while we're doing the procedure. So you see here on the right that we're aspirating fluid, and that's typically what a transudate looks like. Clear yellow fluid. Okay, that's not pus. That's normal. Well, it's not normal, but that's clear yellow fluid, not infected. So while we're aspirating, patient stays still while they're leaning over that table. Minimize talking, try to minimize coughing. It says remove up to 1 liter. I'm going to tell you, if someone has a lot of fluid in their lung, Sometimes we'll remove more because if we don't, they're still going to remain short of breath. So some people are coming in for this procedure purely because they're so short of breath. And then, of course, applying a sterile dressing afterwards. Complications, number one, pneumothorax. We've poked the lung and it collapsed. Internal bleeding, we hit a vessel and now it's bleeding, leading to hypotension. Or we introduced infection. The mediastinal shift is really referring to a complication of the pneumothorax, which is a tension pneumothorax. Okay, that is much more serious. Okay, just briefly on cultures. So we can basically take cultures from any sample of fluid, right? So or any site. We can take wound cultures, we can take throat cultures by just rubbing the back of the throat with a swab, and then putting it in the media and sending it to the into the lab, right? So throat cultures, nasal cultures, nasopharyngeal are very common for viruses. So viruses really like to live at the back of your nose. So nasopharyngeal cultures for certain viruses. And they're sent to the lab and tested for an assortment of bacteria such as strep or staph. Influenza is typically a nasopharyngeal, just like COVID is often the most accurate one is a nasopharyngeal swab. Okay. Before we give antibiotics, we really try to take the cultures because when the cultures return in 2 or 3 days, they're going to tell us exactly which bacteria it is and what's the most sensitive antibiotic. So culture and sensitivity. If we've given antibiotics before taking cultures, we run the risk of not growing anything on the culture media because we gave antibiotics first and then nothing grew when we took the cultures afterwards. Okay. Okay, so sputum studies, they're hard to get, by the way. Often people cough, when they cough, they just give us saliva studies, and we don't send those, right? So if we're going to send sputum cultures or cells, we really need a good sample from a cough, like a really good, thick, tenacious sample. And we send it off, and we try and grow something. Or we can send it to pathology to see if there's abnormal cells. So we can get sputum samples for infections, such as tuberculosis or pneumonia, if someone's really coughing up a lot of phlegm. Or if we're concerned about a malignancy, we can send it to pathology to see if there's abnormal cells. Okay. Best time for sputum cultures is in the morning. Person's had all night to sleep, they're hacking and coughing in the morning, and we get a good sample from the trachea or the bronchial tubes. Okay, definitely we use a sterile container because we want to get what's the bacteria that's truly in the sputum. So we need a sterile container. Okay, so a chest X-ray. Well, I spoke about this at the beginning of this module, so let's just look at it on the left. So right in the middle is the heart, right? So we can look at the heart to see, is there cardiomegaly? Is there an enlarged heart? And we use certain measurements to determine if there's cardiomegaly. We look at the lung fields on each side to see if they're clear. Is there a patch of pneumonia? Is there a pneumothorax, a collapsed lung? Is there a lung nodule, such as a lung cancer? Is there atelectasis after a surgery, for example? Is there a pleural effusion? So all kinds of things we can tell by a chest X-ray. Okay. Contraindicated in pregnancy, not so much. We just apply a lot of protection. Even someone who's not pregnant and goes for a chest X-ray, they're gonna, they should be putting a lead apron on you, or, protection of your abdomen, protection of your gonads. So, we can protect the areas that we don't want to radiate. So it's not really contraindicated because we can protect the fetus in pregnancy. So if we need an X-ray in pregnancy, then we'll get one with with fetal protection, right? Patient takes a deep breath, holds it, X-ray is done, right? The beam is shot through, and we get a nice inhaled view of the lungs, so fully expanded. We can get them standing, which gives us the best view because the diaphragms have gone down, but we can get them, if the patient's too sick, we can get them sitting or even flat, supine, if we have to, okay? We just don't get as good of a view. Jewelry is removed, they have a gown put on, and here's the lead shields, right? Thyroid glands in your neck, ovaries, testicles. We can even cover part of the abdomen. Okay. The three principles are just the amount of radiation that you're going to get. So the time that you're exposed, the distance you are from the radiation, and the shielding. How shielded are you? Okay. So now, typically everyone else leaves the room if there's going to be X-rays. We just leave the room for a second and then come back in if someone's really sick. Okay. But in general, for the patient, it's the time of exposure, so how many X-rays were done. The distance will come into play for other people in the room, and the shielding could be for someone that needed to stay in the room, say a nurse, or someone needed to stay in the room with the patient because they were so unstable, and of course for the patient themselves, the shielding they received. Okay, so a computed tomography, a CT, we can basically CT almost any body part, so head CT, neck CT, looking for intracranial diseases such as strokes, hematomas, hemorrhages, cancers, CT of the neck, looking for a fracture, if we're concerned about a neck fracture, CT of the chest, looking for all kinds of details of the lungs, lung cancer, pulmonary embolus, more detailed view of a pneumonia than a chest x-ray. We can CT the abdomen. We can basically CT almost anything. Okay. Sometimes we'll inject contrast or dye into a vein to give us even more detail of the vascular system that we're performing the CT on. We really try hard not to use this imaging test on pregnant people, right? CT has quite a bit of radiation. Now, if we're forced to use a CT because there's someone who's so ill that they just have to have a CT to diagnose their problem, yes, a CT will be used, but in general, pregnancy is a contraindication for CT unless absolutely necessary. Morbid obesity has more to do with the machine table than the actual test. So those tables are only made for a certain weight. So once that certain weight is reached, the patient cannot lie safely on that table. There are CTs that are for morbidly obese patients because the table can hold significantly more weight. Okay, so patient needs to remain still. A CT takes an incredibly short time now. They're super fast. Okay, you don't need to sit still like for an hour, such as in an MRI. Okay. Typically, your NPO prior, if you're receiving contrast. In fact, we get patients to drink a lot of fluids after they've received contrast to flush it out through their kidneys. Okay, so we tell them to drink lots of fluids prior to the procedure so they're well hydrated if they're going to receive contrast, and also drink lots of fluids after the procedure to flush out the contrast through your kidney system. Okay, so an MRI, again, incredible detail of different parts of the body with an MRI. It uses a magnet. You have to. We can also inject contrast dye with this to get detail of the blood vessels in that area that we're performing the MRI. So lots and lots of detail with an MRI. Again, morbid obesity as a contraindication would be because of the table. Okay, it just can't hold that weight. Claustrophobia, because you have to, most MRIs take anywhere from 30 minutes to an hour to do, right? So you can't have a confused or agitated or uncooperative patient in that donut because they're going to be there for a period of time. CTs, very fast. MRIs take more time. Okay, removing of all metallic objects because they can heat up or they can be pulled by the magnet. Okay, so that we really check for any metallic objects. Patient has to lie flat and still, otherwise the images will be blurry. Okay, earplugs are used because the magnet makes incredible sounds when it's imaging, so it's very noisy in there. Okay, so So fluoroscopy, I'm not going to spend too much time on. It's usually done for procedures because it's a live image. So it's multiple X-ray videos of the area while some procedure is being done. Okay, so if they're doing, say, um, a procedure where they're inserting a catheter into an artery, or sometimes they can use fluoroscopy, which is just giving us a live view using X-rays. Okay, I'm not going to spend too much time on fluoroscopy. Okay, I'm going to move on from this slide because I don't have any end of the chapter questions to do yet. I'll do those moving forward once we talk about other topics. Okay, so the next topic we're going to talk about chest tubes. So chest tubes are inserted for a number of reasons, and they're inserted through the chest wall into the pleural space. So why would we put a chest tube in a patient? Well, say they had a pneumothorax, so a collapsed lung, and we want to reinflate it. We would put a chest tube in to help with reinflation of the pneumothorax. Say someone was in a bad accident and okay, let's say on one side they had a pneumothorax, okay, they'll get a chest tube on that side to reinflate the lung. And on the other lung, they actually have a hemothorax, meaning the pleural space is full of blood. Well, we need to drain that blood out. So that would be another reason for getting a chest tube. Okay, so number of reasons. I would say the most common reason is usually a pneumothorax. But again, we can use it for draining large amounts of fluid out too. So air or fluid. Or sometimes pus. If there's an incredible amount of pus being produced, sometimes we'll put a chest tube in to continually drain the pus out of the pleural system, or the pleural fluid. Okay. So we're going to talk about insertion of a chest tube, then we're going to talk about chest tube systems, and then removal of the chest tube. Okay, so chest tube insertion. Okay, so let's just look at the indications together. So a collapsed lung, a pneumothorax, for sure. We want to help remove the air from the pleural space and allow the lung to re-expand. So a pneumothorax for sure. Hemothorax. So there's a collection of blood in the pleural space, typically from an accident or blunt force trauma to the chest. We want to drain that large collection of blood so that the lung can re-expand to where it's supposed to be. Otherwise, the blood's always going to push the lung out of the way. Okay. Post-operative sometimes, so after lung surgery and the lungs going through a healing process and it's leaking fluid around it into the pleural space, well, patients come out with a chest tube to allow for that drainage. Pleural effusion we spoke about, just a collection of fluid. We can insert a chest tube, especially if it's continually filling up quickly, so we can continually drain the pleural effusion. Pulmonary empyema is basically a collection of pus in the pleural space, and we're putting a chest tube in to drain the pus out, right? So So it's either going to be air or some kind of liquid that we're doing this for. So the procedure, it's going to be somewhat similar to in a thoracentesis. It's just that a chest tube is more significant. It's not a needle, it's a tube. It's got a much bigger diameter, and it's potentially going to be much more uncomfortable inserting it. Okay, so pre-procedure, we cleanse off the area very well, and it's typically the lateral chest. Okay, so we don't typically put a chest tube on the anterior chest. If we're using a full bore chest tube, it's on the lateral chest. Okay, because we don't want to hit any structures that are in the front, right? So we go laterally. Okay, so we're going to administer some pain medication. So often there's an IV in. They're going to be set up to a monitor. We're going to give them some pain medication, maybe some sedation, depending on how anxious they are. And we're also going to try and fully anesthetize with local anesthetic the tissue down to the pleura, just like a thoracentesis, right? So we're going to inject the tissue all the way down to the pleura so that when we open up the area to insert this chest tube, it's somewhat comfortable. Now, the patient can be lying flat for this, so supine, or they can be sitting semi-upright, so in a semi-Fowler's position. And depending on what we're doing the chest tube for, will determine where we want to put the chest tube. So if it's for air, we're going to try and move the tip of the chest tube upwards to the upper part of the chest cavity. If it's for fluid, which of course goes downwards due to gravity, we're going to try and put the tip of the catheter downwards towards the diaphragm so it drains the fluid. So it just depends whether we're trying to drain air or we're trying to drain fluid. Now, once we have the chest tube in place, we're going to secure the chest tube, typically with stitches. Okay, so we don't want that chest tube moving in and out or even being completely dislodged, right? So we're going to stitch the area, including the chest tube, to the chest wall, and then we're going to put a dressing around it, and we're going to attach the other part of the chest tube, so the other end of the tube, to a drainage system that we're going to talk about. Okay, so during the procedure, we're definitely monitoring vital signs, oxygen saturation, blood pressure, heart rate, respiratory rate. Post-procedure, again, vital signs. That's, if we're doing procedures, we're going to monitor vital signs, and we're going to actually encourage coughing and deep breathing. When you take a deep breath, you make negative pressure in your chest. When you cough forcefully, you make positive pressure. And we want to do that to see how the chest tube is working, because we're changing the pressure in the chest, and that's going to alter what we see in the chest tube that we're going to talk about. Okay. So now we'll talk about once a chest tube is in place, well, we want to see what's draining out. So if it's air, we're going to expect some bubbling in this chest tube system that I'm going to talk about. If it's blood or fluid, well, we're going to monitor the volume of blood that's draining out of the chest tube. Okay. Now, the chest tube system that we're going to talk about has to be below the level of the patient to allow for drainage into the system. Okay, it can't be above the level, and it has to be upright. It can't be lying on its side, this chest tube system that we'll talk about. Okay, let's talk about the chest tube drainage system. So these are disposable chest tube systems, okay? And they're all in plastic, and they attach to the other end of the chest tube. So one end is in the pleural space, whether it's to drain fluid, pus, blood, or just air in the case of a pneumothorax, and the other end is attached to this chest tube drainage system. The first chamber on the right is just going to be to collect any drainage, any kind of fluid that's dripping out into the chest tube and then going to the system. The second or the middle chamber is going to be your water seal. And your third chamber is going to be how much suction pressure do we want to apply to the system. Okay. So in a pneumothorax, for example, there's not going to be much drainage. So your drainage collection system, or your first chamber, is going to be relatively empty. Now, we put water, so sterile water, in the middle chamber, the water seal chamber. Okay. Why do we do that? Well, when you, if you have a pneumothorax and you take a breath in, okay, your chest pressure is becoming negative. Okay, so what can we expect to happen? We don't want any air going back into the pleural space, and the water seal in the middle chamber stops any air coming back into the pleural space. Now when you exhale, you have a positive pressure in your chest, and the bubbles are going to go right through the drainage collection and bubble in the water seal, and out they go. Okay, but they can't return because there's that water level there. Okay, so when you take your next breath, you're not breathing back into that air. Okay, so exhaling, there's bubbling in the water seal and it's gone. Okay, now if you take a big breath, I said that you have negative pressure in your chest. Well, then what's going to happen to the water seal container or chamber is the level will rise because you're actually pulling fluid from the third chamber into the second chamber because of the negative pressure in the lung. It's pulling, it's raising the level, and then when you breathe out, you have positive pressure in the lung, and the water seal level will just go down a bit. So that's going to be what's called tidling. So it's just the movement of the fluid with respirations in the water seal chamber. Totally normal. It just has to do with the pressures that are happening in your thoracic cavity. That's it. Okay? So now, if you have a pneumothorax that in the whole system is actively draining air, okay, so every time you breathe out, you exhale, you have positive pressure, it moves some air down the chest tube into the drainage system. Okay, there's no drainage though, just air, and it goes through the water seal and bubbles. So if the bubbling stops in the water seal when you're treating a pneumothorax, it means one of two things. The pneumothorax is completely resolved and there's no air left in the pleural space. Okay, that's great. We can use a chest x-ray to confirm that. Or there's a blockage in the tubing coming from the chest tube, from the lung. There's a blockage somewhere, sometimes with secretions or a bit of fluid, and it's not bubbling anymore. So it's one of those two possibilities. Okay, so let's just look at this slide here. So the water seal we spoke about, it allows excess air or fluid to exit the pleural space. Okay, but it stops the air from going back in because it bubbled through the water seal, but it can't return because the fluid in the water seal is blocking it from returning back into the pleural space. So the tidling we spoke about, that's just the up and down level of the water seal chamber during respirations. During exhalation, you have positive pressure in your chest, so you're going to have a lower level of water in the water seal. When you take a deep breath, there's negative pressure in your chest, the water level is just going to go up, and that's just tidling, up and down, up and down. That's all it is, okay? Lack of tidling, meaning I'm looking at that water seal and I don't see any movement of up and down of tidling, it means the pneumothorax is completely re-expanded, all fixed, or there's a blockage in the tube and there's no tidling because the water seal chamber is not seeing that positive and negative pressure in your pleural cavity. Now, let's say you have a pneumothorax that's just not sealing. It's just continually leaking air and it's not re-expanding. Well, what are you going to have? You're going to have continuous bubbling in the water seal container. It's just never going to get to an end because there's a leak in the lung that's continually creating the pneumothorax. Okay, so that would be a reason for continuous bubbling. Okay. Okay, so let's talk about some chest tube complications. But before that, let's just go back a bit. So we've inserted a chest tube into someone's pleural space to either drain air, in the case of a pneumothorax, or fluid, such as blood, a hemothorax, or pleural fluid that's accumulated, such as a pleural effusion, or pus, in the case of empyema. Okay. Okay, so we have it in the proper position. If it's for air, it's going to be in the upper part of the pleural space, towards the apex of the lung, the top part of the lung. If it's for fluid, we want it near the bottom of the lung, near the diaphragm. Okay, and then we seal the chest tube, or we stabilize the chest tube to the chest wall with stitches. We seal that area with Vaseline impregnated gauze, and then typically we put over a waterproofing seal so that there's no air leak there. The tube goes out and comes to the chest drainage system, and we tape any connection with tape to make sure there's no air leak. Okay. So after this whole procedure has been set up and the chest tube is in, we're going to monitor for vital signs, breath sounds, check the O2 saturation to make sure it's good. Look at the patient. Is he breathing more comfortable? Do they have a good color? Right? And we're going to ask them to take big breaths and cough once in a while, to see what's happening in the chest drainage system. Right? We want to see that titling. Titling is very normal. Remember, if titling isn't there in that water seal chamber, it means either the tube is blocked, and it's not receiving the changes of pressure, or the pneumothorax has completely re-expanded and there's no more bubbles. So titling in general, even after the pneumothorax is completely re-expanded and the bubbles have stopped, you should still see titling, because that's just showing you the changes in the pressure in the thoracic cavity. Okay. Checking the water seal to make sure that there's always enough water in there. Sometimes a bit of water has to be added, okay, to make sure that there's always a bit of water. Now, in terms of the suction, we typically set the suction at -20. Okay, so the suction chamber usually set at around -20. Sometimes we go higher, but not very often. Okay. Documenting excessive drainage from the tube. So if you're getting an incredible amount of drainage back, that needs to be reported, right? So if you're getting 100, 200 mils per hour of fluid, that's a lot. So, the cutoff, I know that's mentioned in the book, is 70 mils per hour. Definitely you want to report that. That's quite a bit of fluid, right? Checking the tubing system for any kinks or occlusions is really important, and loose connections, right? If the chest tube gets loose, or say falls off the chest tube drainage system, well, air is going to get sucked into the pleural space, right? So we want to make sure that they're all secure. Looking at the chest tube insertion site of the skin, make sure there's no developing infection. So sometimes we have to change the dressing. So redness, increasing pain there. We're looking for infection, right? Patients typically need pain medications while they have a chest tube in. It hurts. After insertion, we get a chest tube to make sure the proper placement. Now, we typically don't clamp chest tubes. Okay, it's unusual to have to clamp a chest tube. Okay, because if you clamp a chest tube, especially for a pneumothorax, you could change a simple pneumothorax into a tension pneumothorax. So we would really only clamp a chest tube for a couple of seconds, say if it got dislodged from the drainage system, or you wanted to change the drainage system, we could just clamp it temporarily while we're changing the drainage system. But that would be for an extremely brief period of time. Okay. All right, so let's look at some complications. So three main complications. Air leaks. So it should be a closed system, right? It should be the tube that is in the pleural space. And by the way, the end of the tube that's in the pleural space has little perforations on the side of the tube, so that it's not only the tip that has a hole. There's a distance of the tube that's in the chest that also has holes. And if that tube gets pulled out and one of the holes on the side of the tube comes out beyond the skin, that's a problem. Now you've got an air leak, right? That tube is done. It's finished. It has to be changed. Okay. So an air leak can occur anywhere in the system. So let's start right at the beginning where the tube is in the lung. Say the lung is continually leaking air because there's a hole in the lung that's not sealing in the case of a pneumothorax. Well, that means that the water seal is just going to continually bubble because the hole in the lung is providing more and more air into the pleural space. So you're just going to get constant bubbling. Okay? Or if there's a leak anywhere in the tube, once it leaves the patient, there's going to be air that's sucked into the tube and you'll get constant bubbling. So we always check for all of the connection sites, and we check the tube to see, or we check the tube if there's any continuous bubbling, because at some point the bubbling should stop once the lung has re-expanded. Okay. Okay, let's go to the next one. So tension pneumothorax. So this is the reason why if someone had a chest tube for a pneumothorax, we wouldn't clamp it for any prolonged period of time at all, right? Because now there's nowhere for the air to go, right? The reason you put in the chest tube was to drain the air out of the chest. So if you clamp it, you've blocked that, and you could turn a simple pneumothorax where the lungs just collapse, but it's not, there's no pressure in the pleural space, and you could turn it into a tension pneumothorax, okay? So we don't clamp very often. The other cause of a tension pneumothorax is the tube got kinked somewhere. So kind of the equivalent of it being clamped, it just got kinked. So if it's kinked, well, it's the same thing, the air can't get through. So the air in the pleural space is stuck and it could turn into a tension pneumothorax. Okay. What about accidental disconnection? So the chest tube accidentally gets pulled on and it gets disconnected. Okay, well, if the tube gets disconnected, we usually get the person to breathe out as hard as they can, so they can take a breath. Breathe out as hard as you can, because if you breathe out, remember what's happening, positive pressure in the chest. So that means they're not sucking in air into the pleural space. Okay. So they can cough and exhale, and then you can take the end of the tube and either reconnect it to the chest tube drainage system where it got disconnected, or you can put it in some water, okay, in some sterile water. And what's that going to do? Well, there's not enough pressure to suck water back into the lungs. So just putting the end of the tube in some sterile water it's going to seal again, right? I hope that makes sense. So attaching it back to the chest tube drainage system, or just putting it in some sterile water. Okay. Now, if the whole tube gets pulled out, well, it's done. Okay, you can't push a tube back in. So we never do that. So if a tube gets pulled out, then we just dress the area, So we put sterile gauze on it and seal it where the hole was. Okay, so the top one here, accidental disconnection. So that's why we have sterile water in a container at the bedside, or it's just sterile water at the bedside. That if the tube that's connected to the drainage system gets disconnected, you can either just quickly reconnect it to the drainage system, or you can put it in sterile water, and that will stop air from rushing back into the chest from an open chest tube. Okay. Now, if the chest tube completely comes out of the chest wall, well, that's where the occlusive dressing comes in, right? So the person can exhale or cough, and that creates positive pressure in the chest, and then we're just putting an occlusive dressing on the chest tube hole that was there. Okay. Now, you would also have clamps or a hemostat at the bedside, because if you're changing the chest tube drainage system, you can clamp it for a very short period of time. So it's not that's not unusual, but definitely you could not prolong. You could not apply a hemostat or a clamp to a chest tube and then just leave it because of the risk of developing a pneumothorax. Okay. Now, what about a scheduled chest tube removal? Okay, well, this person's going to need something for pain. So it's usually going to be an IV opioid, such as fentanyl or morphine or any one of the opioid analgesics. And we're going to loosen the sutures, okay, because the chest tube was attached to the chest wall with sutures, so we're going to cut those. And then we're going to ask the patient to take a breath in and to bear down, to exhale and bear down. Okay, so a Valsalva maneuver. What does that do? Positive pressure in the thoracic cavity. So, because if you had negative pressure when you're taking the chest tube out, say during inhalation, they're going to suck air, and the pneumothorax could, or the resolved pneumothorax could collapse again, and you're back to square one. Okay, so they bear down, they breathe out, and they push down hard, positive pressure while you're taking out the chest tube. Okay, and then we apply an airtight Vaseline or a petroleum jelly gauze to the chest tube hole, and then we put very strong tape over it to seal it, so that there's no air that could potentially get into the hole and into the pleural space. And then, of course, we always get a chest X-ray afterwards to make sure that the lung didn't collapse again and another pneumothorax has happened. So we get a chest tube removal chest X-ray afterwards. Okay, and then of course we watch the site for potential infection or drainage or anything like that. Okay, so at the end of chapter 18 are some questions. Let's do them together. So a nurse is preparing to care for a client following chest tube placement. Which of the following items should be available in the client's room? Oxygen, for sure, right? If you're having a chest tube put in, you could cause all kinds of complications that you might need oxygen, right? You might irritate the lung. You might cause a pneumothorax if you were putting it in just to drain fluid. So you need oxygen there for sure. Sterile water, that's a good idea. Why is sterile water a good idea? Because once the chest tube is in, what happens if the other end of the chest tube that's attached to the drainage system comes loose? Well, you could either reattach it to the drainage system or just put it right into sterile water and stop air from being sucked back into the chest. So sterile water is a good idea. Enclosed hemostatic clamps in the room. That's a good idea too, right? So they need to be available in case there's some kind of air leak somewhere and you have to very briefly clamp the tube, okay? Or they need to be available if you need to change the drainage system to a new one. So you would just briefly clamp the tube change the drainage system, and release the, release the clamp. Okay. Indwelling urinary catheter, no, that shouldn't be part of this at all. Occlusive dressing, for sure, right? So what's the occlusive dressing for? What happens if the whole chest tube gets pulled out? It needs to be immediately, an occlusive dressing needs to be applied to the chest. So it should be A, B, C, and E. Yeah, good. A nurse is caring for a client who has a chest tube and drainage system in place. The nurse observes that the chest tube was accidentally removed. Which of the following actions should the nurse take? Obtain a chest x-ray, apply sterile gauze to the insertion site, place tape around the insertion site, assess respiratory status. So really the first thing is put the sterile gauze to the insertion site, because if the whole chest tube comes in, you have a hole there. So every time the person takes a breath, they're sucking in a bit of air into the pleural space, right? So you're not going to wait and get a chest x-ray. You have to seal that hole. So it should say applying a airtight sterile gauze dressing. That would be the most accurate. But B is still the most accurate here. Placing tape at the insertion site, that's not good enough. Assessing respiratory status, well, you still know you have to seal that site right away. So the answer is B here. Okay, next question. Nurse is assessing a client who has a chest tube and drainage system in place. Which of the following are expected findings? Continuous bubbling in the water-sealed chamber. No. At some point, the bubbling should stop, because the bubbling, if you have a pneumothorax, every time you breathe out, okay, little bubbles will occur in the water-sealed chamber until the pneumothorax is fully expanded, and then there's no more air in the pleural space. The bubbling stops. Okay, so continuous bubbling in the water-sealed chamber means there's an air leak somewhere. It's not normal. It should stop. Gentle, constant bubbling in the suction control chamber. So that one is accurate. So when someone takes a breath with a pneumothorax, okay, so the drainage system, the drainage chamber may be totally empty if it's for a pneumothorax, and then the water seal is the next one. So you'll have some bubbling in the water seal, and then you'll have some bubbling in the suction chamber because it's taking the air out and removing it, right? So the suction chamber is taking the air and clearing it. Rise and fall in the level of water in the water seal chamber with inspiration and expiration. Yes, tidling, right? That's just the changes of the pressure within your thoracic cavity with breathing. So that's just tidling, that's normal. Exposed sutures without dressing, no. The sutures that are holding the chest tube on your chest should have a nice water and airtight seal around them. You should not be seeing sutures. Drainage system upright at chest level, no. Drainage system has to be below the level of the patient, and it should be upright as well. Okay. Okay, so the answer there is B and C. Okay, for that one. Let's go to the next. Number 4. A nurse is assisting a provider with the removal of the chest tube. Which of the following actions should the nurse take? Instruct the client to lie prone with arms by the sides. No. That's going to make it really hard to get to the chest tube if your arms are by your sides, because typically the chest tube is on the side there. Complete a surgical checklist on the client. Okay, I'm going to leave that one. I don't think so. Remind the client that there is a minimal discomfort during the removal process. That's not true. That can be quite uncomfortable, and that's why we give medication for pain prior to the chest tube removal. Place an occlusive dressing over the site once the tube is removed. Absolutely. Right? You want to seal that hole. So the answer there is going to be D. Okay. A nurse is planning care for a client following the insertion of a chest tube and drainage system. Which of the following should be included in the plan of care? Encourage the client to cough and deep breathe. Yes, right? When you cough and deep breathe, when you take a deep breath, there's negative pressure in your chest. So you're going to see that titling. When you cough, you're creating positive pressure and you're moving air down the chest tube or fluid down the chest tube into the uh, the uh, the chest tube drainage chambers. Okay. Okay, so A is good. Check for continuous bubbling in the suction chamber. Okay, so the suction chamber is the third chamber. So there should be a bit of bubbling in the suction chamber that's showing you that there is ongoing suction taking place in that chamber. Because say you set it to -20, so there's a bit of suction taking place in that chamber and bubbling. Strip the drainage tubing every 4 hours. No, we don't. We don't do that, right? So D, clamp the tube once a day. No, we try really hard not to clamp the tube unless absolutely necessary. And E, obtain a chest X-ray. Yes, following a chest tube, we want to see the location of where the tube is in the chest, right? You wouldn't. It's amazing where chest tubes can end up. They can end up in the tissue, not even in the pleural cavity. They can end up all over the place. So definitely we get a chest X-ray, okay, afterwards. So the answer is A, B, and E. Okay. Okay, so this is the last third of this module, and we're going to talk about some breathing exercises, oxygen therapy, oxygen delivery systems, incentive spirometer, nebulized medication, so small volume nebulizers, non-invasive positive pressure ventilation. We'll get to that. Mechanical ventilation, so that's where someone's intubated and now on a ventilator, and a tracheostomy. Okay, I won't spend too much time on this slide because we'll move on to the individual topics. Okay, so breathing exercises is just what it says, right? So for someone who's very anxious or stressed, or someone who comes in acutely short of breath, and they're looking very anxious, or with certain exacerbations such as COPD, or someone who's in pain and breathing really abnormally fast, we can do some breathing exercises. So just coaching the patient to breathe slowly and rhythmically, right? And to exhale completely when they're breathing. So our breathing goes off when we're stressed or we have air hunger in certain respiratory conditions, or say a COPD exacerbation, or if we're in severe pain and we're breathing fast, right? So we want to slow that down a bit. Inhaling through the nose. So that allows the filtration action of the nose, humidifying the air through the nose, and warming the air through the nose. Okay, so inhale through the nose when someone is really acutely short of breath. Okay, prolonging the exhalation time. So inhaling is usually much shorter than exhaling. Remember, inhaling is an active process. Exhaling typically does take longer. So you get someone to take a breath in and then breathe out slower, right? It's more of a relaxation technique as well. Okay. And we keep air. So someone who's receiving oxygen, we have to start humidifying the air or oxygen because it's going to dry out their nose and their mouth. So we have to humidify the air after a while. Not for an hour or two, but if someone's on it for days, we have to humidify it. Pursed lip breathing is typically when someone's in, so they take a breath and they're really short of breath, and when they exhale, we ask them to pucker their lips, or what's called pursed lip breathing. And what that does is when you pursed lip breathe, you actually are not allowing the air out really quickly when you're exhaling. And by doing that, it puts back pressure on the lungs and the alveoli, and it keeps them open. So pursed lip breathing is actually a way of keeping the alveoli open. And in fact, COPDers do it naturally when they have an exacerbation. They have what's called pursed lip breathing, where it looks like they're puckering their lips a bit. And really what they're doing is the body has discovered that if you breathe that way, it's putting back pressure to the lungs and stopping the alveoli from collapsing on themselves. Tripod breathing is where you're gripping the ends of a table, and you're tripoding. You're stabilizing your chest, and because you're so short of breath that you need that stability with your arms, um, to to use your accessory muscles, to get air in and get air out, right? So that's tripoding. When someone's tripoding, it usually means they're in trouble. They have a respiratory condition and they're in respiratory distress. Okay, so let's talk a bit about oxygen therapy. There's all kinds of ways of giving oxygen. Um, that is higher than room air. Remember, room air is 21%, right? So if someone has a respiratory condition or a cardiac condition and they're hypoxemic, meaning they have low oxygen in their bloodstream, is going to result in hypoxia, which is low oxygen at the tissue level. So we want to maintain proper oxygenation for the patient. Otherwise, the tissues are going to see low oxygen levels, which is going to harm the tissue, right? Whichever organ we're talking about. Okay, so what's the management? So provide the lowest flow that will correct the hypoxemia. So if someone has some asthma and their oxygen level is 88%, so their O2 saturation is 88%. Well, if they just need 2 or 3 liters of oxygen per minute, well, that's all we're going to get. If that gets them up to 95%, great. So we don't dial it up really high if we don't need to. Okay. So we can adjust the oxygen flow rate. We can adjust how we want to give the oxygen. Like what method do we want to give it in? And we usually start with simple methods, and if they're not effective at raising the oxygen level in the blood, then we'll go to delivery systems that can deliver higher and higher concentrations and flow rates of oxygen. Okay. So the humidifier, so typically we're going to start humidifying oxygen, because if someone's on continuous oxygen, it's going to dry out their mucosa in their nose and their mouth, and they're going to start to get some skin breakdown or nasal irritation, okay, and a very dry mouth. So we start humidifying the oxygen, or the oxygen that we're delivering. Okay, so what are the reasons why we deliver oxygen to someone? So someone comes in and they're short of breath, and we're assessing them, and we may just put some oxygen on them until we can figure out what's causing the shortness of breath, what's your O2 saturation, and then we can always adjust the oxygen, okay? Low O2 saturations from any cause, right? So whether it's from congestive heart failure with a whole bunch of fluid in your lungs, or COPD, or asthma, or pneumonia, we want to get the oxygen saturation in the blood up, because oxygen is what feeds tissue, right? So we don't want to keep people with low O2 saturations. There are some circumstances, such as in COPD, where we don't want to give them high flows of oxygen because they're chronically at a lower level of oxygen in their bloodstream. And by giving them a lot of oxygen and keeping their O2 saturations very high, it's going to turn off what's called their hypoxic drive, and they're going to slow down their breathing, and that can lead to what's called CO2 narcosis. They're going to build up CO2 and they're going to get really tired and lethargic, and those patients can end up having to be intubated because we gave them so much oxygen that we turned off their hypoxic drive. Cyanosis, just another, so cyanosis, that blue appearance of the lips, the fingernails, or the nail beds. Sure, that's deoxygenated hemoglobin. So that's another indication of low O2 saturations. So we would give oxygen, right? Just remember that high flow oxygen has some toxicity to it. So we rarely keep infants, for example, and neonates on high flow oxygen because high oxygen levels needlessly can cause free radicals in your body. And it can be toxic, especially to neonates. So we're careful not to overdo it with the oxygen because of its toxicity. It's flammable. So if someone says, I smoke at home, but the person needs home oxygen, they cannot smoke around the oxygen. It's flammable. Okay, so that's not a good combination. Oxygen-induced hypoventilation is just what I spoke about before. The patient with COPD that is used to an O2 saturation at 88% all the time, and they come in and they're shortness of breath, and they're short of breath, and we dial up their oxygen to 98% on an O2 sat monitor. That's too much for them. The body's going to say, oh, there's so much oxygen in the bloodstream, I don't need to breathe as fast. And then they slow down their breathing. What happens then? The CO2 starts to climb in their bloodstream, and CO2 makes you tired and lethargic, and they start to lose consciousness. And when they lose consciousness, that means we may have to intubate them. Okay, so that's what's called CO2 narcosis. Okay, that's typically in COPDers. Okay, so how can we deliver oxygen? Well, the one on the upper left there is just nasal cannula, right? So they're the easiest. We often put those on first, unless we see that someone's oxygen saturation is critically low and we know that they're not going to be enough. So those little prongs go into the nostrils, and typically we give them flow rates of about 1 to 6 liters per minute. Okay, that's going to give an oxygen delivery of about 24%. Remember, 21% is room air, so 24% to about 40, 45% in that range. We can't turn it up much more beyond 6 liters because it's going to hurt the nose. It's going to be really irritating. Okay. So they're typically comfortable. They're really easy to put on. They're usually well tolerated as long as it's not at high flow rates, and the person can eat, talk, drink, right? So we're not blocking their mouth. Okay. The disadvantage is if the person's mouth breathing, not much oxygen is going to go in because we put that into the nose. So if they're mouth breathing a lot, it's hard to know how much oxygen they're getting in. Another disadvantage is it's going to potentially break down and dry out the skin in the nose, right? So sometimes we have to put lubrication in the nose, and we humidify the air. And also those little nasal prongs get dislodged, and it's amazing where you find them on patients. If they're sleeping, they might be up near the eyeballs, they might be wrapped around near the ears, and they're not very useful there. Okay, so there's definitely pluses and minuses to them. We definitely humidify the oxygen if we're getting up to the higher flow rates of 4 to 6 liters per minute. Okay, next one, simple face mask. So that's the one right beside the nasal prongs to the right. That's a simple face mask. I can deliver slightly higher flow rates. We can turn up the oxygen a bit more, 5 to 8 liters per minute. That's going to give you 40 to 60% oxygen. Okay, so the nasal prongs didn't work, didn't quite get the O2 sat high enough, we'll convert to a simple face mask. Usually well tolerated, but some people start to dislike it. They can't talk, they can't drink, they get a bit anxious with this mask on them all the time. So it's not fantastic to wear all day long, right? And some people that have decreased levels of consciousness can vomit into that and then aspirate it. So there's some pluses to it, but there's also some disadvantages to using this. Okay. You have to make sure that it's a proper seal. So when you put these masks on, they kind of have to go under the chin and then over the nose, so that there's a nice seal for the patient. Okay. And then typically what we do is we switch them back to nasal prongs when they're having a meal or drinking. Okay. Let's go on to the next one. And that will be the fourth one. So the top row, but the fourth one is, well, that one could be a partial rebreather mask, or it could be, it's not really a non-rebreather, but basically it just has a bag with it, a reservoir bag. So it's a simple face mask with a reservoir bag. Okay, and we can turn up the rates a bit higher, so 6 to 10, 6 to 11 liters per minute. It'll give you more oxygenation. Okay, and the reservoir bag is basically holding on to some of the oxygen that's going on, and also some of the air that you're exhaling. Okay, and there's no valve between them. So when you inhale, you get some from the oxygen that's coming through the tubing, and some from the reservoir bag. Okay, so usually we go right to what's called a non-rebreather mask. And a non-rebreather mask has the mask portion that goes over a patient's face, and then it's attached to a reservoir bag that's filling with oxygen. Okay, so when you take an inhalation, you're getting oxygen from the tubing that's coming from the wall, and you're getting the oxygen that filled up the reservoir bag. Okay. When you breathe out, none of your exhaled air is going into the reservoir bag. It's going through ports in the mask, so it's leaving. So the next inhalation you take, you're getting high flow oxygen from the tubing and from the reservoir, because there's a valve, there's a one-way valve there. Okay, so it gives you really high flow rates of oxygen. So you'll see flow rates of oxygen, 80% oxygen, 90% oxygen with a non-rebreather mask. Okay, so if someone comes in critically ill and their oxygen saturations are low, we're going to put on a non-rebreather mask. Okay, highly anxiety provoking, and if you're claustrophobic, you're not going to like it. But these are usually people that are really short of breath. Okay, and we want to get the one of the highest flow rates of oxygen into their lungs. Okay. Okay, so the Venturi delivery system, or Venturi mask, there's nothing fancy about it. It's the same kind of mask, but then you can see these multicolored plastic attachments, and you just choose one, and it just allows you to choose the most accurate oxygen concentration and flow rate. That's all it does. Okay, so there's nothing fancy. We actually don't use these that often, but basically the mask goes over it. You choose one of those plastic devices that you attach in line with the tubing, and it just allows for exact oxygen concentrations. Okay. And again, this is someone, say we want to know the exact oxygen concentration they're getting. Say it's a COPD, or so a chronic condition, and we want to make sure we don't give them too much oxygen. We might use a Venturi mask for that. Okay. So as I said, compared to nasal prongs, simple face mask, and a non-rebreather, these are used much less frequently. Okay, so the far right on this slide with the straps, we're going to talk about that. That's going to be non-invasive ventilation. such as what's called CPAP and BiPAP, where we attach that sealed mask to someone's face, and then we strap it around their head really firmly, and we can apply pressure to the air going in. So CPAP is continuous positive airway pressure. And we'll talk about those, okay? Bottom left, the second image is an endotracheal tube for intubation. And the third image on the right is a ventilator. And the fourth image on the right, I'm not completely sure of. I think it's just a humidifier. Okay. Okay, we'll come back to those, but here's just an incentive spirometer. Nothing about oxygen. All we want you to do is, say after surgery or say after you've fractured ribs, we want you to take deep breaths. Okay? So these usually come with a little blue ball in them, or if you look at this image on the left, there's a little orange that say it's either going to be a ball or some device that's going to go up and down when you take a deep breath. Okay. So by taking a deep breath after surgery, you're preventing atelectasis. You're preventing the alveoli from collapsing all over the place because you're taking these nice deep breaths. So really an incentive spirometer is really to prevent atelectasis. And why do we want to prevent atelectasis? Because that is collapse of alveoli, and that can lead to pneumonia. So we remind people, we want you to use the incentive spirometer every hour to take deep breaths to prevent atelectasis and pneumonia. Okay, so we just have to show them how to put this device in their mouth, take some nice deep breaths, and usually the ball goes up to the top of the device, and we want them to hold it there by taking a deep breath. Okay, so a small volume nebulizer, or we just call it a nebulizer. Well, we can attach this, so we can attach this to a simple face mask. And if you look at the image on the top right there, there's a little plastic canister that we can put medication in. So we could put albuterol in there, we could put ipratropium in there, and we typically use these nebulizers to deliver medication into the lungs. Okay, usually for a COPD flare-up where we're putting albuterol and ipratropium in the nebulizer, or for an asthma attack. Okay, so in the bottom image, you can see there's a canister, and that's where we pour the medication into. We often combine albuterol, and sometimes we add some ipratropium, which is an anticholinergic medication, to the albuterol, which is a beta agonist, to bronchodilate during a COPD or asthma flare. So definitely the patient needs some education in terms of taking some nice, deep, regular breaths to get the medication into the lungs. Rinsing the chamber after, of course, is a good idea. So some of these patients are doing this at home, so rinsing the chamber afterwards just to clean it out. How do you know that the medication is working? It's misting out the end of the tube where they're breathing, right? There's a mist coming out because you've actually attached this either to air or to oxygen on the wall, and it's bubbling through the medication and creating a mist. Okay, so definitely patients can have these at home, or we use them all the time at the hospital for albuterol or ipratropium delivery. Okay, so non-invasive positive airway pressure I mentioned. It keeps the airways open and improves gas exchange. Okay, so they're both used. Okay, so continuous positive airway pressure, so CPAP. CPAP is used for sleep apnea, and what does it do there? It just constantly delivers pressure to the back of your throat, and it stops your tongue from occluding your airway, and it stops the pharynx, all the muscles of the pharynx from collapsing and occluding your airway. So it's basically stenting the airway so that you don't snore and you don't get sleep apnea, right? We can also use this for someone who has a COPD flare in the emergency room. We could use it for someone who has an asthma flare, okay? Um, Now, what's it doing in that case? Well, it's delivering pressure to the airway, even when they're exhaling. So you would think, well, that's going to make it harder for them to exhale. Well, it does a bit, but what's it actually doing is it's keeping the bronchial tubes, it's pressurizing the whole system to keep the bronchial tubes and the alveoli open. So it's definitely a treatment for asthma, for COPD, and for congestive heart failure. So if someone in pulmonary edema and we don't want to intubate them, we're trying our best not to, we can put them on CPAP or BiPAP. What's the difference between BiPAP and CPAP? Well, CPAP is continuously always the same pressure. Whether you're inhaling or exhaling, it's just one pressure, and we can choose the pressure. BiPAP is bi-level, so meaning we can choose more pressure when you're inhaling, and when you're exhaling, we'll cut down on the pressure. So there's an inhalation pressure and an exhalation pressure. And again, we can use this for a COPD flare. We could use it for congestive heart failure, just to maintain the bronchial tubes open and to keep the alveoli open. Okay, so that's what these are used for. CPAP is the one that's used for sleep apnea, not BiPAP. Okay. Now you can see it in these images that the mask has to really be well sealed onto the face. You can't have any air leaks, otherwise the airway pressure is going to be zero. The machine's not going to be able to deliver the pressure to the airway because it's leaking out somewhere. So in the bottom left image is a very common one that we use, where we have all these straps, and it really seals the mask to the face and around the nose, and delivers that pressure into the lungs. Okay, so let's talk about mechanical ventilation. So mechanical ventilation is a ventilator. So the patient needs to be intubated first, right? So we sedate them, we give them analgesia, we use a paralytic, and we intubate them with an endotracheal tube. Then we inflate the cuff that's near the end of the endotracheal tube. And now we have two options. Once the patient's been intubated, we can either use a bag valve mask that we have to manually contract, to ventilate them, or we attach them to a mechanical ventilator. So why would we do this? Well, say someone is extremely hypoxemic, and no matter what we do, any of the airway devices that we spoke about, such as nasal cannula, masks, non-rebreather, nothing is enough to maintain oxygenation in the bloodstream. So they're extremely hypoxemic, say from a huge pneumonia. Well, we can put them on a mechanical ventilator. Say someone is hypoventilating from an opioid overdose, or they're just getting really tired because they've been breathing very fast and they've been working very hard to maintain ventilation, and they're just tiring out. Well, those people need to go into a mechanical ventilator. Okay, so an asthmatic that we see is starting to get tired and more tired, they're not breathing, they're slowing down, well, sometimes they have to go into a mechanical ventilator. Respiratory acidosis basically means your lungs are failing, and that's why you're getting the acidosis, right? So a COPD, or again an asthmatic, or someone with severe pneumonia, they're now getting acidosis in their bloodstream. We'll intubate them so we can control the level of CO2, and indirectly we can control the pH of their bloodstream by intubating and mechanically ventilating them. Respiratory failure, for sure. So for any cause of respiratory failure, whether any asthma, COPD, pneumonia, any airway failure, Guillain-Barré syndrome, myasthenia gravis, anything that you can't maintain ventilation or oxygenation would warrant a mechanical or a ventilator. Someone who's really confused and has a decreased level of consciousness, say a head injury patient. Well, there's nothing wrong with their lungs, but they have a decreased level of consciousness. So if they vomit, that vomit may well go into their trachea because they have a decreased level of consciousness. So it's typically more than just confusion. They're starting to be unconscious, okay? And that they need an airway to protect their airway. So they need an endotracheal tube. Controlled hyperventilation would be someone, again, with a severe head injury. And we know that if we hyperventilate them and get their CO2 a bit lower than normal, so CO2 in the bloodstream is usually 35 to 45. If we can hyperventilate them and keep their CO2 around 25, well, that causes vasoconstriction of the cerebral arteries, and it can reduce intracranial pressure. So controlled hyperventilation for a head injury. Increased work of breathing, so watching someone breathe very, very quickly and working extremely hard, and they're sweaty and they're holding onto the table, you know that they're going to run out of energy. And we try all kinds of other interventions such as albuterol, ipratropium, CPAP, BiPAP, and everything's failing. Well, they need to be ventilated. They need an endotracheal tube and a ventilator. Okay. Okay, so let's talk about endotracheal intubation. So that's the process typically through the mouth. You can do nasotracheal intubation, but by far the most common is endotracheal intubation through the mouth. And it's the process of getting this endotracheal tube through the vocal cords and into the trachea, but above the two bronchi. So before the division of the trachea to the bronchial tubes. Okay, so it's above the carina, which is where the trachea then splits and becomes the left and right main stem bronchi. Okay, so oral intubation is by far the easiest and the fastest way to intubate someone. Okay, nasal intubation can be difficult. Sometimes the tube is too big for the nostril. We can cause bleeding or trauma within the nose. So we typically go for oral intubation. Okay. So what do we need for this? Well, we have to have rescue medication. Rescue devices in case we are unable to ventilate. So we need a bag valve mask. Okay, so that if we need to remove the tube because we weren't successful, we can supply them with oxygen. Okay, and give them enough oxygen to have a second attempt, right? So we don't want to be spending 2, 3, 4 minutes trying to intubate someone. So if we find that we're not being successful, we'll remove the tube and we'll re-oxygenate them and attempt again. Okay. So, what do we need for this? So we need an endotracheal tube, the right size. And on the end of the endotracheal tube, you'll see that there's a inflatable cuff in this image. And when we get it into the trachea, we'll inflate that cuff, and that's going to hold it firmly in place, and it's going to stop any air leakage around it. So it's going to be a closed system from the tube that's at the mouth right into the trachea so that we can attach this to a ventilator. Okay. Now, most of the time we use cuffed tubes. Sometimes in young children we'll use an uncuffed tube where we don't have to inflate that bulb at the end, because in children we can just put the tube down and it kind of just seals itself as the trachea gets smaller. So that's only in children, uncuffed tubes. Almost always we use a cuffed tube. Okay. So once we have this tube in, well, first of all, let's go back a bit. What do we need in terms of medications? Well, we need definitely something for pain, and it's going to be an IV opioid such as fentanyl. because this is a painful procedure. We need to completely sedate the person. Okay, so we can use a very powerful IV sedatives such as benzodiazepines or propofol to completely sedate them so they have no recollection of this. And we have to take away their gag reflex, so they have to be completely unconscious, otherwise they'd be gagging as we're putting this tube down. So pain medication such as fentanyl, a very powerful sedative such as propofol, and a paralytic agent such as succinylcholine or rocuronium to paralyze them. Why do we want to paralyze them? Because we want to paralyze all those muscles in the throat and the neck so that it's easy to get this tube in. So we can open up the mouth very easily and we can see the vocal cords and there's no muscles that are fighting us and we get the endotracheal tube in. Okay? We inflate the cuff and then we need to check that it's in the right position. So we usually use what's called an end-tidal CO2 monitor. So the end-tidal CO2 monitor actually goes on the end of the tube that's at the mouth. And it tells us exactly how much CO2 is coming out. So if the tube is in the esophagus, the CO2 level will be close to zero. If the tube is in the lungs, the CO2 level will be detected because there's CO2 coming from the lungs. So that's what we typically use, an end-tidal CO2 monitor. Okay? We attach the patient to the ventilator, and then we can adjust the respiratory rate and the volume of air or oxygen that we want to give with each breath. Okay, so that's what we control on the ventilator, the respiratory rate and the volume per breath that the machine is going to push into the lungs. After that, we listen to breath sounds on both sides to make sure that there's air going into both lungs. We look at the chest to make sure that both sides of the chest are going up and down with respirations. We secure the tube that's at the mouth with a device that will stop it from sliding in and out. Okay, we want to keep it at a certain level or a certain depth. The patient's definitely on a monitor that's watching the end-tidal CO2. They're on an O2 sat monitor. They're on a cardiac monitor. And we always have the suction ready in case they vomit while they're unconscious. And we want to suction vomit out of their mouth. Okay. We always get a chest x-ray after an endotracheal intubation to see exactly where the end of the tube is. We want it to be above the carina, so in the trachea still. Okay. So how can we see how well we're ventilating and oxygenating someone? So the O2 sat monitor is going to give us a good idea of the oxygen saturation, but sometimes we'll get an arterial blood gas, and that's going to give us the pH of the blood, the PaO2 of the blood, the PCO2 of the blood. So it's going to give us more information. Okay, so we'll use arterial blood gases to adjust the dials on the ventilator to get them just right in terms of the proper amount of oxygen, proper amount of CO2. Now, weaning a patient that's on a ventilator just depends on what condition they have. So if they have severe pneumonia, they might be on the ventilator for days or weeks. If they had a really bad flare-up of asthma and we were able to get it under control after a day or two, well, then they'll be weaned off the ventilator as quickly as possible. Okay? So it just depends on what the underlying condition is. That'll determine how long someone's going to be on a ventilator. So when someone's on a ventilator and they're intubated, they need very close monitoring. So they're always going to be on a cardiac monitor. They're always going to have an O2 sat monitor attached to their fingers. They're going to have an end-tidal CO2 monitors to see that there's CO2 coming out of the system because, say, the tube got dislodged at some point and now it's in the esophagus. Well, we would know that really quickly if we had an end tidal CO2 monitor on, because if it's in the esophagus now, then we know we'll detect it because the CO2 is drifted down to zero during exhalation. Okay, so that's really important because tubes can sometimes get dislodged and we might not know. And because the patient's sedated, we may not know that the tube's been dislodged. Okay, so very frequent assessment of the respiratory system, vital signs, repositioning of the patient frequently. Okay, obtaining arterial blood gases to see that we have the ventilator settings um, in a good range for them, to make sure that their PaO2 is good, to make sure their PCO2 is in the normal range and their pH is in the normal range. Okay. Some patients, once they're on a ventilator, we can start to withdraw the sedation, but just maintain the pain medication because it's so painful to have this tube in your trachea. And they start to wake up and they're able to write, communicate with a board. Of course, they can't talk because the tube is right through their vocal cords, so they're unable to verbalize it all. Okay. So in terms of medications, what are the common ones? Fentanyl, that's for pain. Propofol, that's purely for sedation. And paralysis, we have a whole bunch there. Succinylcholine, rocuronium, vicuronium for paralysis. That's usually for the intubation process. You don't need to be paralyzed for days, usually, when you're intubated and you're on a ventilator. Okay, it's usually for the intubation process. So what is this mechanical ventilator achieving? So whether it's through an endotracheal tube, or whether it's, say, through a tracheostomy, which is a device that goes into the trachea in your neck, and then you're put on a ventilator, what's it achieving? Well, it's pushing oxygen into your lungs. Remember, naturally, you're sucking oxygen or air into your lungs because your chest is negative pressure during inhalation. A ventilator doesn't do that. It's pushing air, so it's supplying positive pressure to force air or oxygen into your lungs. So it's not a natural way of receiving oxygen. Okay? So it basically just forces the lungs to expand and then relax and then expand. And that improves gas exchange for someone who's not able to oxygenate. The other thing it does is if someone was really gasping to breathe, they don't need to gasp anymore because the machine is working for them to deliver the oxygen. Okay? So typically it's through an endotracheal tube, but if someone is going to be on long-term ventilator, then they may need to be converted to they may need to have a tracheostomy tube surgically put into their trachea, and then the ventilator attached to that. So what are the potential people that will end up on a ventilator? Well, basically anyone who's hypoxemic and we can't get their oxygen to a safe level for them. Okay, so someone who's had trauma to their airway and they can't ventilate, someone with a severe COPD flare-up, and they're tiring out, they're starting to lose consciousness, and they're starting not to breathe because they're fatiguing. Someone who has congestive heart failure and their lungs are filled with fluid and they can't maintain oxygenation. Well, we will intubate them and put them on a ventilator. Someone with a severe head injury that's unconscious, and if they vomit, they'll aspirate. Someone with a stroke that's unconscious, and if they vomit, they'll aspirate. Neurological disorders where they're not able to ventilate themselves, right? We spoke about ventilation, perfusion, diffusion. So say you have a nerve problem such as myasthenia gravis or Guillain-Barré syndrome, and you're not able to ventilate because the muscles aren't being stimulated, well, they're not going to be able to oxygenate themselves, so they need a ventilator. Okay. So let's move on from this slide. Okay, we're going to talk about some complications, but before we get there, let's just talk about this person that now is intubated and on a ventilator. Okay, so we need to, and the cuff's been inflated, and the endotracheal tube has hash marks on it to tell us exactly how deep it is. So once we have it at a good position, okay, we will document on the chart that we have it at, say, 14 centimeters or 18 centimeters. Just depends on where the proper placement is. Okay, and we'll mark it. So it tells us, we look at where the tube is going through the teeth, and there'll be a hash mark there. It'll tell us exactly how many centimeters down the endotracheal tube is. Okay. Remember, the patient often needs repositioning. The patient sometimes will need restraints in case they accidentally grab the tube and pull it out. Okay, so some kind of soft restraints. Being very careful when you move the patient because you could dislodge the endotracheal tube. Okay, suctioning of the oral mucosa of the mouth is important because there's secretions that are still being secreted into the mouth, so they need suctioning. Suctioning of the endotracheal tube itself. So we put suctioning devices down to suction all the mucus, especially patients with pneumonia or that are producing a lot of bronchial secretions. Okay. We always need to have a resuscitation bag in the room in case the ventilator stops working or the tube gets pulled out accidentally. Okay. As mentioned before, these patients need ongoing analgesics, typically IV analgesics, morphine or fentanyl, because it's painful. Okay, they often are receiving some kind of sedative because otherwise they're fully alert of having this tube in their trachea. So propofol, a benzodiazepine such as diazepam or lorazepam. Sometimes we'll give them antacids, such as an H2 blocker, so famotidine, or a PPI, such as omeprazole, because the body's under a lot of stress, and the stomach can start to develop what's called stress ulcers. Okay. What else do I want to mention before we get to complications? I think it's clearly stated in the book, the rest of it, so let's go to complications. So the first one is barotrauma. So I mentioned that it's not natural to have oxygen being pushed into your lungs. So usually oxygen or air naturally goes just by negative pressure in the chest and it gets sucked into the lungs. So we can actually injure the lungs because the machine is pushing oxygen into it. So that's barotrauma. And that can lead, if say we're setting the dials at high volumes, well, if we inflate the lungs too much, that could lead to a pneumothorax. So we could actually pop a lung and they get a pneumothorax while on the ventilator. Okay, so that's not good. And the other terms, subcutaneous emphysema, pneumomediastinum, those are that's just air in different parts of the chest wall or in the chest itself because of the pneumothorax. So really the complication is barotrauma leading to a pneumothorax. Okay. So volutrauma, I wouldn't worry so much about that one. But again, we're careful with how much volume of air we're delivering or volume of oxygen, because we can injure the lungs by giving them too much volume or too much pressure from the machine. Okay. Next one, fluid retention. So why would you retain fluid? Well, again, it's unnatural to be forcing oxygen positive pressure into the lungs. So because the chest is under positive pressure, less blood can return back to the chest from your legs because it's always under positive pressure. It doesn't have that negative pressure of you taking nice breaths naturally. So less blood flow back to the chest, it's going to pool in the legs. Okay. Oxygen toxicity. Well, we already spoke about the fact that high flow oxygen and a ventilator delivers a lot of oxygen. Oxygen can injure the tissue if it's too much, right? So high concentrations of oxygen for long durations, for days, injures the tissue of the lungs. Okay. Hemodynamic compromise. Why is that? Well, it's the same idea. I'm pushing oxygen or air into your lungs instead of you inhaling it naturally, and I'm stopping the blood return to the chest, meaning blood return to the heart, and that can cause low blood pressure because of decreased venous return. So the blood is not returning to the heart, so the heart can't pump blood that it's not getting. You can become hypotensive, tachycardic. And if you're hypotensive, you're not making much urine because your kidneys are now not seeing the blood and they're going to reabsorb all the fluid, right? Because of the renin-angiotensin-aldosterone system. So hemodynamic compromise can occur with mechanical ventilation. Aspiration for sure, right? You have a tube through your vocal cords. If you were to vomit or even just have the secretions in the back of your throat leak around the tube into the lungs because you're also unconscious, right? So aspiration, developing an aspiration pneumonia. So suctioning is very important. Stress ulcers, we mentioned, those gastrointestinal ulcers when the body's under stress. And that's why we use PPIs or H2 blockers to cut the acid, reduce the acidity in the stomach. Okay. Ventilator-associated pneumonia. Well, what is that? Well, you have a tube in your trachea that's pushing oxygen into your lungs. So a foreign body basically is in your trachea, and you're at risk of developing ventilator-associated pneumonia. Okay, because this is not a natural process. It was necessary. It just wasn't. It's just not natural. So what do we do to try and prevent some of these conditions? So ventilator-associated pneumonia we can try and prevent by a couple of things. Elevate the head of the bed, okay, to at least a semi-Fowler's position. What's that going to do? Well, it's going to push the diaphragm down because of gravity, so the ventilator doesn't have to work as hard. It doesn't have to push and apply as much pressure to the lungs, okay, to get that oxygen in. Okay, so we typically keep people in a semi-Fowler's position, not completely supine, because otherwise the chest wall is heavy and the ventilator is having to push at higher pressures. Reducing the sedation. Remember, some patients can be on a ventilator without any sedation, as long as they have the proper pain control. So reducing the sedation, what's that going to do? Well, it's going to improve level of consciousness, decrease the risk of aspiration. And so does elevating the head of the bed. It reduces aspiration from the stomach, right? Peptic ulcer disease prophylaxis, good idea to prevent acid from your stomach aspirating into your lungs, causing a pneumonitis or a pneumonia. DVT prophylaxis because you're immobilized on a ventilator. You're not going anywhere. You're stuck to this bed. You can't. You're sedated. You're on pain medication, and you're attached to this ventilator. And very good oral care. Okay, with an antiseptic such as chlorhexidine. Proper suctioning is really important. Oral suctioning, endotracheal tube suctioning, all to prevent ventilator-associated pneumonia. Okay, so extubation considerations, just quickly. We can definitely irritate someone's vocal cords. Some patients can be hoarse for weeks to months afterwards. So once they've been extubated and they need oxygen, we definitely humidify it to try and stop irritating the vocal cords after being extubated. Voice rest, right? So you've had this tube through your vocal cords for days or weeks. So after it's been removed, not to talk a lot. So rest your voice, which is resting your vocal cords. The possible need for high flow oxygen, that's possible. So when someone's extubated, they may still need high flow oxygen even though we've taken them off the ventilator. How do we monitor the oxygen? Well, with the O2 sat monitor, the pulse oximeter, and if we want a really accurate reading of what's going on in the arterial system, and arterial blood gas from the wrist. Okay. Assessing the need for reintubation, well, that's going to be based on how someone's breathing, how they look, the work of breathing. Are they getting more and more short of breath? Are they breathing faster and faster again? Is their O2 saturation dropping? Is their arterial blood gas measurements worsening? They may need to be reintubated. Okay. Okay, so a tracheostomy is just a more permanent access to the airway, right? So it's a surgical procedure where the trachea is accessed and there's a connection to the skin right to the trachea where um, we can insert a much shorter tube, and it's more for long-term use of ventilators or someone who say has oral cancer or laryngeal cancer and they need um, a tracheostomy to ventilate and to oxygenate. Okay. So, what are the complications of having a tracheostomy? Well, the tube can definitely dislodge. Okay, so if you look at that image of a tracheostomy tube, it can definitely dislodge. I'm going to tell you, it's not usually the end of the world if it dislodges because the hole is still there. Okay, so it's not pleasant for the patient, but they're pretty easy to reinsert. Bleeding, that's definitely a concern. If there's a lot of blood coming up the tracheostomy, that would be a big concern. Okay, because there's some arteries that live next to the trachea, and if the trachea is injured and affects one of the arteries, they can really bleed through a tracheostomy tube. Aspiration, well, sure, you don't have your normal way of getting air into your lungs, so you could you could you could aspirate from your airway, so from your larynx down the vocal cords into the trachea, and of course you have a foreign body in there, right? So there's a risk for developing infections and pneumonia because of this foreign body. Laryngeal nerve damage. So there's a nerve that's very close to your trachea called the laryngeal nerve that supplies a nerve to your larynx, to your speech. So that can be impacted. Okay. The tube can get obstructed with thick mucus and secretions, and we have to change it or clean it. I mentioned infections, dysphagia, so that's difficulty swallowing, can sometimes occur. Now, sometimes with this tube in place in the trachea, over time, it can form a connection just because of the tissues being close together and this tube in there. You can form a connection between your trachea and your esophagus. Okay, well, that's not good because now you have a little hole, like a fistula, it's called, between your trachea and your esophagus. So, guess what can happen? Some fluid can reflux up your esophagus and get into the trachea, causing recurrent pneumonias. Okay? Ischemia and necrosis of the local tissue can occur because this is a tube that's putting pressure on local tissues, and if it's too big of a tube, for example, it can harm the local tissues because it's putting pressure on them and blocking blood supply to them. Okay, in the interest of time, I'm going to leave this slide. I think it's pretty self-explanatory. Um, I'm not going to spend any time on this. I'm going to keep on going. Okay, so let's do some of the questions at the end of the chapter. Just want to review a couple of things first. So what is mechanical ventilation? So mechanical ventilation is where we use an automated machine to maintain proper levels of oxygen and proper levels of carbon dioxide in the blood. Okay, so some people call it a breathing machine. But the goal is to maintain oxygenation and maintain normal levels of CO2. Okay, how does it do that? By delivering positive pressure into the lungs. Okay, so the machine is actually forcing oxygen through that to the endotracheal tube into the lungs and forcing them to open. Okay, so really mechanical ventilation is a form of life support. Okay, in someone who's critically ill, say with sepsis or severe pneumonia. So the ventilator can provide the full cycle of breathing. So it can do the inspiration and it'll stop pushing air or oxygen into the lungs, and then the patient will have an exhalation. Okay, so the patient actually doesn't have to do much work because the machine is doing all of it. Okay, so it doesn't take as much energy to breathe when you're on a ventilator because the machine is using its own energy. Now, most of the time, we have someone on a ventilator while we're trying to treat the underlying condition that put them on the ventilator. Okay, so all we're doing is breathing for them while we're treating the underlying COPD flare or the underlying asthma flare up or the severe pneumonia they have and they can't breathe for themselves. So whatever it is, we're still treating the underlying condition, plus we're providing oxygenation because they were unable to do it for themselves. So let's think of the main advantages of putting someone on a ventilator. So the first one is it reduces the work of breathing by the patient and of course the patient's respiratory muscles, right? It helps maintain oxygenation of the blood. So we will get oxygen into the blood by a mechanical ventilator. It gives some stability to the patient in terms of oxygen levels, CO2 levels, while we're trying to heal their underlying illness. Okay? And by ventilating someone, it's removing the carbon dioxide and maintaining oxygenation of the blood and the tissues. Okay, so how can we choose? So once someone's on a ventilator, how can we choose how to deliver the oxygen into their lungs? So we go to the ventilator and we can choose the respiratory rate. Okay, so say we choose 18 breaths per minute on the ventilator. Okay, so it's going to deliver 18 breaths per minute. What else is an option? Well, we can choose whether we want to deliver a set amount of volume of oxygen. So that's called volume control. Okay, so say we want to deliver 500 milliliters of oxygen, we would turn the dial to 500 milliliters, and the machine is just going to listen to us and deliver 500 milliliters of oxygen per breath. Or we could go, instead of volume control, we could choose pressure control and tell the machine, I want you to deliver oxygen until you reach a certain pressure within the chest, and then I want you to stop. I'm going to tell you, most of the time, it's volume control that we use. Okay, the vast majority of the time. But just so you understand that concept of, we can tell the machine to deliver a set amount of volume of oxygen, or we can tell the machine, deliver oxygen until you reach this pressure in the chest and then stop. Okay, so we're not going to talk about all the ventilator settings. It's not possible, and all the different modes of delivery of oxygen. But just keep in mind, I mentioned I can choose how much volume to deliver per breath, or I can choose how much pressure should the machine continue to deliver oxygen until you reach that pressure and then stop. Okay, so let's talk about what's called assist control. It's a mode of ventilation. So this is one of the more common ones. And what is it? Well, we choose the volume. So we choose how much volume we want to put into the lungs, and we choose the time interval. So how frequent we want to deliver it. Or if the patient takes a little breath, it's going to trigger the assist control to help the patient take that breath. Okay? So that's a very common way of using a ventilator. So it's going to deliver a set volume at a set time interval, unless the patient takes a breath before. And then if the patient does take a breath, it'll assist the patient in taking the breath. Okay, so let's talk about another one. Synchronized intermittent mandatory ventilation. And I didn't invent that word, so SIMV. So what does this mean? So again, we've set the ventilator to a certain volume of oxygen that's going to be delivered and a certain number of breaths per minute. Okay. Now, say the person takes a breath. If the person takes a breath, the machine, the ventilator, allows the patient to take the breath, and it will include it in the total number of breaths we've chosen per minute. Okay? So if we choose 20 breaths per minute and at a certain volume, if the patient doesn't breathe at all, okay, it's going to deliver 20 breaths per minute. If the patient takes, say, 5 breaths in that minute, the ventilator will deliver the remaining 15. So really, in the assist control mode, the ventilator's taken over. It's choosing the respiratory rate and how much volume it's going to deliver. In the synchronized intermittent mandatory ventilation, the machine says, okay, I'm going to get to a set number of breaths, but if you do half of them, I'll do the other half. Okay, and that'll make sense when we do some of the questions. Okay, let's do some of these questions, and hopefully it makes sense. Okay, so number 1, a nurse is caring for a client who is receiving mechanical ventilation, okay, and is on pressure support ventilation. Mode, okay, so which of the following statements by the nurse indicates an understanding of pressure support ventilation? So the word is support here, okay, so it's just helping the patient. So it keeps the alveoli open and prevents atelectasis. No, I'm gonna tell you about that just for a minute. So when someone's exhaling while on a ventilator, there's potential for all the little alveoli to start to collapse, especially if they have pneumonia or ARDS. So what we do is we can set a bit of pressure that's called PEEP. So positive and expiratory pressure, meaning when the person's exhaling, we can set it so that there's still some back pressure in the lungs, and it stops the alveoli from collapsing, and it prevents atelectasis. So it keeps the airway and the alveoli stented open even during exhalation, and we call that PEEP. Okay? So we can choose a PEEP of 0, or we can choose a PEEP that's much higher to put more back pressure and stop alveoli from collapsing and developing atelectasis. So that's not the answer here. It allows preset pressure delivered during a spontaneous ventilation. Yes, that's what pressure support ventilation is, meaning the patient takes their own breath and the machine says, oh, I just sensed that you're taking a breath. I'm going to help you out by adding some pressure and forcing some oxygen for you. So that's pressure support. Okay? It guarantees minimal minute ventilator. No, it doesn't guarantee that at all. Okay? It delivers a preset ventilatory rate and tidal volume to the client. No, that's assist control. Okay, so assist control is we choose the respiratory rate, we choose the amount of volume, and boom, the machine's going to do it. Okay, so basically the machine is just breathing for you on assist control. Okay, so the answer is B there. Just pressure support means when you take a breath, the machine's going to help you out. A nurse is caring for a client who is experiencing respiratory distress. Which of the following early manifestations of hypoxemia should the nurse recognize? I don't really find this one easy. Early, late, middle. I find these somewhat confusing. So the first answer here, confusion. Confusion is usually a late finding in hypoxemia. So your oxygen levels are starting to drop. Your CO2 levels are starting to climb as your lungs are failing. And the combination of low oxygen and high CO2 leads to confusion, lethargy, decreased level of consciousness. Okay, so it's a bit late. Pale skin, that can definitely happen as an early manifestation of hypoxemia. Okay, so the sympathetic nervous system is turning on and shutting down blood supply to the skin because it knows the body's in trouble and it's trying to shut down non-essential organs such as the skin. Okay, so pale skin can certainly happen. Bradycardia, that's an indication that the heart is in trouble because if you were hypoxemic, you would be normally at the beginning tachycardic. So as the heart becomes more and more hypoxemic and hypoxic, the heart is starting to get in trouble and it's starting to shut down. So bradycardia. Hypotension, another late finding. The heart is starting to shut down. Okay, so decreased cardiac output. Elevated blood pressure at the beginning, yep. So the sympathetic nervous system is on. That's why you have the pale skin. And that's why you would have the hypertension, because the system's been activated to try and maintain oxygenation to the brain. So B and E would be the correct answer. Not an easy question. 3, a nurse is caring for a client who is receiving mechanical ventilation via an endotracheal tube. Very common way to receive ventilation is the endotracheal tube. Which of the following actions should the nurse take? Apply a vest restraint if self-extubation is attempted. No, we wouldn't restrain the chest at all. They've been intubated for probably a respiratory problem. So we're not going to put anything around the chest to impede their breathing, right? If anything, soft restraints of the wrist to stop them from touching the endotracheal tube. Monitor ventilator settings every 8 hours. Definitely not. Those ventilator settings are checked very, very frequently. There's often alarms going off. So no, every 8 hours would be much too infrequent. Typically every hour. Document tube placement in centimeters at the angle of the jaw. No, we document tube placement at the teeth. Okay, not at the angle of the jaw. And remember, there's little hash marks on the tube. It'll tell us exactly how many centimeters at the teeth. Assess breath sounds every 4 hours. That's a good idea to make sure that the ventilator hasn't caused, say, a pneumothorax in one side and that you're getting good air entry bilaterally. Okay, so it's D. A nurse is caring for a client who has dyspnea, so shortness of breath, and will receive oxygen continuously. Which of the following oxygen devices should the nurse use to deliver a precise amount of oxygen to the client? Okay, so the most precise instrument we have for delivering, or delivery system, I should say, for delivering a precise amount of oxygen is the Venturi mask. So it's just a mask, and it has different size fittings that allows different airflows in them. And on the other slide, you'll see that it's the little plastic fittings that matter. So for example, if we want to deliver 30% oxygen, we'll choose a Venturi fitting of 30%. 35, that's another fitting. 40, another fitting. So if someone has really, say, severe COPD and we want the exact oxygen delivery, we would use a Venturi mask because we can reliably say this person's getting 35% oxygen. Okay. A nurse is reviewing. By the way, the one that delivers the least amount of oxygen is the nasal cannula, and then simple face mask, and then the one that delivers the highest amount of oxygen is the non-rebreather mask. Okay. Number 5, a nurse is reviewing the plan of care for a client who is receiving mechanical ventilation. Which of the following ventilator modes will increase the client's work of breathing? Okay, so if the ventilator has totally taken over, it's going to decrease the work of breathing of the patient. So which one has increased the work of breathing, meaning the patient's breathing a bit and they're having to work? So assist control, no. Assist control means I have chosen the heart rate and the amount of volume that the ventilator is going to deliver, and it just delivers it. That's it. Synchronized intermittent ventilation is, okay, I've chosen the respiratory rate, I've chosen the amount of volume, but if the patient wants to take half the breaths, go ahead. So that's going to increase work of breathing for the patient, because if they're breathing half the time, they're using their own energy. So B would be correct. Okay. C, continuous positive airway pressure, that's CPAP. That's just the mask that we put over someone and we pressurize the airway. So it's not even with an endotracheal tube. Okay, it's just to pressurize the airway while someone has sleep apnea, or they have, say, a COPD or congestive heart failure, and we're pressurizing the airway to keep it open. But it's going to make it harder to breathe, because when they exhale, they're exhaling against some positive pressure. Okay, so C is going to be right. Pressure support ventilation. So pressure support ventilation is when the patient initiates their own spontaneous breathing, and then the machine kicks in to help add more pressure to the lungs, to push the oxygen in. So it's pressure support. So is it going to increase the work of breathing? Well, compared to the machine doing everything, absolutely, right? So because it's triggered by the patient taking the initial breath in pressure support. Okay, so D would be correct. Independent lung ventilation, I'm not even going to get into that. There's a whole bunch of other modes. That's just going to cause confusion. So B, C, and D are the answer. That's not an easy question at all. Okay, so don't feel totally overwhelmed, because that's definitely not an easy question. Okay. I'm not going to do this slide. Delegated acts for licensed practical nurses and nursing assistants. I'm going to leave that for you to study and read. Okay, let's do this question together. So a nurse provides education to a preoperative client regarding use of an incentive spirometer. Definitely these are used post-operative, by the way, as well. Identify the sequence the client should follow. Place the steps in selected order of performance. Okay, so let's have a look at this. So we're going to have the patient sit up, okay, in bed. And what's the goal of an incentive spirometer is to prevent atelectasis. That's why we usually use it post-operatively. So it usually comes with a little ball that's going to go up and down in this chamber. So we can set it so that when we take a nice big breath in, the ball's going to go up, and you want to hold it there. So the sitting up is the first part. Creating a tight seal around the mouthpiece is the next one. Taking a nice big breath or a big inhalation is the next one. Holding it for 3 to 5 seconds is going to be the next one. okay? And then once you've held it, you can now exhale, okay? And then you repeat it 10 times, okay? So it doesn't take very long to do. This is often a post-operative because patients that have had surgery that are lying flat or in bed, they can develop atelectasis, right? Alveolar collapse all over the place, which predisposes them to not only low-grade fevers, potential to develop a pneumonia, okay? So sitting up, create a tight seal, take a big breath. So inhale deeply, hold it for 3 to 5 seconds, exhale, and repeat. Okay, so we're done this module. On average, they're going to be around 3.5 hours to 4 hours. There's just a lot of material. And if I can give you more detail on material, I will. It won't mimic the book. I'm trying to follow the book, but it's definitely not going to mimic the book. Otherwise, there wouldn't be much use in doing it. So I hope this helps you with understanding the book more and understanding the processes that are happening more and the treatments and diseases and so on. Okay, so I'll see you at the next, I'll talk to you at the next module. Bye.